live on YouTube. We have about 100 people on Zoom at this moment, and I'd say about 100 or so here and in the other room. And we're also live broadcasting to White Plains and Nyack, all part of the MonteHeart system. I want to briefly introduce the faculty. I came here 9 years ago, and this was the initial group. Dr. Shin, Patel, Sims, and Torres, but we quickly recruited Dr. Murthy, and then recruited Saeed, Chavez, Vukovic, Madan, and Rochlani, and all of the heart failure attendings now have an important role somewhere in the MonteHeart system for various areas, from sarcoidosis to pulmonary hypertension to heart transplantation, and you can look at the titles and you can speak to them later. We speak 9 native languages, so we can accommodate almost everybody who comes to our system, and have also trained, and we're very proud of that, many international leaders, including the current director of heart failure at Tel Aviv University, Dr. Milvitsky, was with us. And later on, you will hear from Dr. Diaz from Barcelona, who will return to Barcelona after 1 year to run the MCS program at Barcelona University. We're funding from the NIH, AHA, and various foundations, not enough funding. And we're also complemented by an exquisite surgical team led by Dr. Goldstein, who is the co-director for this meeting. Just an incredible team throughout this system. This is the entire program there. We have social workers, secretaries, nurse practitioners, dietitians. We have an incredible staff in the CCU and CSICU here at Montefiore. And we have now grown from just being a heart failure program here at Moses to a system. And we'll get to this in more detail. And all the sites that you see here are active sites where we see patients with heart failure. Or a need for transplantation or an LVAD. We staff all of these sites, and right now, this meeting is broadcast to all of this site. We're developing a unified approach for the system, and I have to say that all of this at the moment is executed by our staff here at Moses and our extremely good nurse practitioners, social workers, and our administrators, Gabriela and Lucy. What are we doing? We're improving care, not just medical care in heart failure, but also critical care. We're one of the few heart failure groups in the country that entirely runs the cardiac intensive care unit. Here's just one paper written by Dr. Sims that shows that since our involvement in the union, mortality for all conditions has declined, has decreased. Sorry, mortality has declined often. We're also extremely proud to be an innovative center. And as you may have seen on the news, only about 9 months ago, for the first time in the world, we used intentionally an HIV positive organ to transplant a patient of ours who has HIV. This made the news in a big way. And I'm very proud of that on behalf of the whole team, because it's rare that you do something that nobody has ever done before. And we did that, and we're extremely proud. And of course, it is published in the Journal of Heart and Lung Transplantation as a first in the world. Many other papers. I don't have time to go over the about 40 to 50 papers our team publishes every month, but here are just looking back the past month. There was a New England Journal of Paper of Medicine this week on DCD transplantation. Danny Goldstein is a co-author on this. David D'Alessandro is the senior author, a former Monty surgeon who now runs the Harvard program, and of course will be a speaker here, and he will be today and speak tomorrow. We've also branched out into structural heart disease. If you've seen last month the triluminate study in the New England Journal, I was co-author of this paper, and we have enrolled many patients right here. We have been at the cutting edge for a while. There's now a 10-year update on mechanical circulatory support that is in press. And Dr. Rochlani, Patel, myself from here on this paper, and also Dr. Jose Gonzalez Costello, who you'll meet later on, who is the director of heart transplantation at Barcelona University. ECMO is something that we're at the cutting edge, also papers in JACC. And then yesterday, the Columbia group did their international journal club, and they presented Dr. Madan's paper on early outcomes of adult transplantation from COVID-19 infected donors. I'm not going to go into detail here. You will hear more about all these studies throughout the course of the next 2 days. In the United States, the highest level of scientific recognition is getting a fund from the National Institutes of Health. And Dr. Said, who will also speak to us later, is currently NIH funded and submitted last week an R1 grant that, if funded, will be about $2 million, and very few people get that. And I think you can count practicing heart failure physicians like Dr. Said, who can run in the ICU, who can do a cardiac biopsy, getting NIH funding on one, maybe two hands throughout the United States. So extremely proud of that. Danny Goldstein and I started this years ago, but we got an incredible addition about 3 years ago, I think, Azim Latif, who, of course, is currently on a plane from Paraguay, where he did a new device, but will join us later today. This is Azim right here. This is Mei Chao from surgery, and this is Edwin Ho doing an echocardiogram. This was live last week. We were in Phoenix at a meeting, and they were broadcasting a case from Weiler Hospital globally with a major international meeting. So Dr. Latif will join us later and missing the morning session. So we're going to go basically to the cutting edge of transplantation, mechanical support over the past 50 years to current, and then look into the future. Everybody probably knows who this is, also anybody who can read, because it says Dr. Christian Barnard right there. Most people won't know who this is. And many of you might not recognize this device. This is Adrian Kantrowitz, who was a surgeon actually at Montefiore before he defected to Maimonides Hospital, where he then almost performed the first heart transplant in the world. It's an interesting book about it. Every Second Counts, it's called. You should read it. But probably more impactful, he invented the balloon pump, which he's holding in his hand right here, which is a big topic that you will hear a lot about today. So I told you we're looking into the future. We like NIH funding. This is Dr. Castagna, who is one of our graduating fellows, who will go to a lower institution in Boston for a year and then return to us. And he just published this paper on balloon pump in the ASAIO journal, and also submitted an NIH grant on this. I believe this type of research is in heart failure the future. We always worry how to pay the bill. People have been worrying about this for at least 50 years, maybe longer, which brings me to the recognition of our supporters. I really want to I want to acknowledge Abbott, Abumet, Boston Scientific, and Transmedic, who gave us unrestricted educational grants for this meeting. We couldn't do a meeting like this with industry support. This meeting costs, believe it or not, about $80,000 with CME, audiovisual, the brochures, and that's just about how much we bring in. Also, I want to thank all the exhibitors. If you have seen the hall outside, please go check it out. They're also supporting us financially. There's some general statements here. You can get up to 12.75 CME credits for this meeting. All this is mentioned in your brochure, also for the fine print. We really need you to evaluate the meeting after. You're going to get an email. Please fill it out. Spend just 5 minutes. Make some concrete suggestions. Don't just say it was great, but say it was great, but I didn't like this part, make this shorter, make this longer. Why didn't you mention X, Y, and Z? And I think this just gives you the various codes. All of this is in your brochure. If you can silence your mobile devices, because now we're going to move to the biggest challenge of the meeting, which is going to be coordinating the various sites. So can we bring on, just after I'm done with the introduction, you should switch it to Nyack. Dr. Murthy is at Nyack. We have a clinic there. We see patients there. Oh, there she is. Amazing. So, hey, Sandhya. So Dr. Murthy, I showed you in the first picture, came, has been really part of the senior partners now, excuse me, Sandhya, but is really a leader, and I think a national leader at this point in pulmonary hypertension, heart failure anywhere. We all do heart failure. And Sandhya is going to give us the first lecture. We have to start sort of at the ground level. So Sandhya will give us a lecture on medical therapy live from Nyack. Thank you, Sandhya.
Okay, thank you, everybody. I've been tasked with this arduous AV issue. So let me try to bring up my screen here. Give me 1 second.
Just walk. Let's stay here. Just walk her through it if she needs something.
Oh, sure.
Yep, we should be good. All right. So 9 o'clock in the morning, let's talk about the guidelines. And I hope that at the end of this, we'll see why this is a 4-drug cocktail. And I'll provide some data on the newest kids on the block, so to speak. And the only disclosure I want to make is that I have trouble saying empagliflozin and dapagliflozin. So I will be referring to them as empag and dapa throughout this talk. So some nuts and bolts first. I want to first define how the guidelines looks at HFrEF in relation to LVEF. So traditionally, it's been described as an LVEF of under 40%. And the reason for this is really, this is where we're applying our latest guideline-directed medical therapy to the EFs of under 40%. They've added an interesting subgroup here, which is the HF improved EF, which is an LVEF of under 40%, which recovers at some point, so follow-up of greater than 40%. And the HF mid-range or mildly reduced EF is in the 41 to 49% range. And then the HFpEF is traditionally described as LVEF over 50%. Now, the reason it's broken up like this is that we've come to recognize that our traditional GDMT that we prescribe for HFrEF may not be as effective in these 2 middle classes, which is the HF mid-range, and certainly HFpEF is a whole different ball of wax, which Dr. Shin will walk you through. There's many ways to describe heart failure. We can describe them with the AHA-ACC guide stages, which is A through D. A is this interesting at-risk group, and that's not really who this talk is really applied to. We're really talking about C and D, basically anybody that has structural heart disease that has had a clinical heart failure episode. So we can describe them with this structural appearance of the heart as well as symptoms, but also describe the functional class with the NYHA system. And we have a class 1 with no limitations of physical activity all the way to class 4, which is shortness of breath on minimal, at rest. The advanced heart failure profile is really related to the NYHA class 3 and 4, and the Intermax has been used to describe patients who are requiring advanced mechanical support. So this is really also not as applicable to what we're speaking about, but our guidelines generally will stick to ACC, AHA class C with variable NYHA classes, usually 2 through 4. Okay, so taking back to the first medical therapy for heart failure, this is the foxglove plant. This was an English physician in the 1700s, and this plant was ubiquitous throughout the countryside of England, and it was often prescribed by local healers to help, young women with edema. And he was the first to note that there was a strong diuretic effect associated with. And he also noticed that if you drink too much of this tea, you would have retching and diarrhea, which may have only aided the diuretic cause. So this is the origins of digitalis from the foxglove plant. And this was really the only therapy available for hundreds of years. There was also advanced mechanical therapy in 1900s. This is the Salvi tubes, if anyone's ever seen this. And basically, it was a mechanical removal of edema using a kind of a system of suction with a basically a trocar that was inserted with a IV line and draining the edema physically from the legs. It wasn't until the 1950s that thiazide diuretics came into play. And then what's always interesting to me is that Dr. You already pointed this out earlier with the 1967 Time magazine article. Now remember, 1967, that's 20 years before any GDMT. Our first trial, with VHEF was 1986. So about 20 years before we focused on recovery and maintenance of heart failure rather than just replacing this old heart. So 2019 survival, and this is kind of the pitch to why this is so important for us to think about. Even in the modern era with our great therapies, we have a 10-year survival of under 40%, 5-year survival, 60%. So this is still a very relevant and very important to kind of think about in context of what we can do to improve survival. The main bullet points that I think is really important to point out here, that the lifetime risk of heart failure is still very high, especially after 45 years of age. And while the flavor of heart failure has changed throughout the years, meaning that HFpEF is increasing while HFrEF is decreasing, both of these subtypes still cause an unacceptably high mortality rate and equivalent mortality rates. And this is where the plea for contemporary heart failure therapy comes in, where we can improve the risk of dying by 62%, cardiovascular death or hospitalization by 62% compared with limited conventional therapy. What was that? It was digitalis and Lasix. So this is a very relevant topic even in the current era. This is quite a busy slide, but what I wanted to really focus on is the step one all the way to your left-hand side. So we have now 4 therapies that have been shown to improve survival, and I'll walk you through some of this data. And then we have diuretics, and all of these are class 1 indications and applying to stage C LVEF under 40% to remind you, and symptomatic, meaning NYHA 2 to 4 class. So this is a timeline from 1986, as I mentioned, the first VHEF trial, all the way to 2020. Now, it's not so important to go through every single one of these, but I wanted to kind of focus the broad, look at the colors here. We have the grays, we have the blues, we have the light blues, all pre-2013, 2014. All of that is dealing with 2 main pathways, the RAS inhibition pathway and the neurohormonal axis. So those were the only 2 mechanisms that were focused on in the pre-2014 era. So we have the peaches and the greens down here as the kind of the advent of surgical therapies. But by and large, our limitations have really been on focusing on 2 different pathways. Finally, 2019 and greater, we have some color in the slide, and this denotes novel pathways. And this is kind of the recognition over time that perhaps we need to think beyond just our dual pathway, RAS inhibition, neurohormonal blockade, and think about outside the box, so to speak, about different ways to target this disease, given that consistently our survival isn't where we should be. So let's focus first on RAS blockade. And there are some new things that in the last 5-10 years that we can talk about that are very exciting for us. So the first obviously is the neprilysin inhibitors along with the ARB. In 2014, 2019, these are the 2 big trials that put Entresto on the map. So totally there's been about 5 large randomized controlled trials with Entresto. And it has come to the point where now this is the preferred RAS blockade. So I want to just kind of dive down into the recommendations a little bit. So this is coming from, again, 5 major randomized trials, level of evidence A. The HFrEF, which is basically class C, and NYHA 2 to 3 symptoms, ARNI is the preferred drug to reduce morbidity and mortality. And there are certain scenarios where you wouldn't use an ARNI, and that is if there was some hardship in obtaining the ARNI, such as financial issues or et cetera, then you can consider ACE inhibitor. The other reason is if you've had angioedema to an ACE inhibitor, an ARNI is contraindicated, and in that scenario, an ARB is recommended. So really only two scenarios where you wouldn't consider ARNIs as your first line. And again, these are the two biggest trials, the Paradigm and the Pioneer trial, which basically mirrored each other in the results, in that enalapril versus Entresto, or the ARNI, basically had an improved survival. And the primary endpoint was a combination of heart failure, hospitalizations, and death. So I don't want to spend too much time on the ARNIs, because we have the focus here is really to talk more about the SGLT2 inhibitors, which is the new kid on the block here. So I had to go back and kind of figure out basic renal anatomy to try to describe this. And I won't go into too much detail because Dr. Shin will really be doing a lot of discussion on the SGLT2 inhibitors. But just to remind everybody, this is our nephron. On the lower hand picture, to the blood glucose gets filtered through this nephron and ends up in the proximal tubules. So now you have the proximal tubules full of glucose that is coming from the blood, and you are uptaking this glucose with sodium using these sodium glucose link transporters, or SGLTs. So what the inhibitors do is they block this pathway. So what you're left with is a lot of sodium and a lot of glucose that are not being filtered. Now, 90% of the glucose is filtered in the proximal tubules. So if you're blocking that reuptake here, then what you're doing is essentially you're wasting glucose. You're losing glucose through the urine. You're losing sodium through the urine. And where sodium comes, that's where the fluid comes too. So it causes a glycosuria and natriuresis at the same time. So obviously, this was the first kind of, hint that perhaps this is a great drug to use in diabetes. Depending on how much glucose is in the serum here, you would be able to avoid reabsorbing it and improve your serum glucose levels. So this was a novel kind of thought for diabetes. And in the mid 2000s was when they first started looking at this for diabetes. And it was recognized right away that diabetes is a risk factor for heart failure. And we've known this for many years. And the effect of the SGLT2 on lowering serum glucose is moderate. Now, if your GFR is lower, basically you are not that the glucose from your blood is not going to reach the nephrons at such a high rate, so that obviously the efficacy in glycemic control is lower. But what was recognized right away is that the cardiovascular benefits were still maintained, even if you weren't filtering the glucose, even if your GFR was decreased. So it was way beyond just lower glucose control that led to improved cardiovascular benefits. And that wasn't really a satisfying explanation to why these patients did better from a cardiovascular standpoint, knowing that once your GFR is reduced, you're not really gaining the benefit of lowering glucose control, yet the cardiovascular benefits were still there. So let's kind of go through some of the possible mechanisms. What about just diuresis? So you diurese, you probably lower your blood pressure. That's got to be good for heart failure. But again, these drugs work in normal glycemic patients. If you're normal glycemic, you're not going to waste glucose. You're not going to waste sodium. The diuretic effect is attenuated, yet the benefit remains. So that's not the complete explanation to why they work. And then why not just use a loop diuretic? Isn't that the same thing? We're just kind of diuresing. Well, there's an important distinction here that loop diuretics will decrease the plasma volume, which means that there's a lot of sodium inside the urine. And what you're doing is you're creating a scenario of hypoperfusion for the kidneys, and that the kidneys sense that your plasma volume is lower, the RAS system is activated and kind of worsening the RAS and neurohormonal cascade of heart failure. So that's the important distinction. Whereas SGLT2 inhibitors, they selectively secrete the interstitial fluid without affecting the volume. Now, where is this coming from? This was a nice study. It's called the RECEIVE-CHF trial. And what they did is they looked at the urine sodium in patients on loop diuretics and the urine sodium on patients with an SGLT2 inhibitor. And what they saw is that the urine sodium was much higher in patients on loop diuretics. And so the way to think about it is that the SGLT2 inhibitors cause a hypoosmolar kind of lots of fluid loss, almost like ultrafiltration, not so much creating this hypoperfusion effect on the kidneys. So what does all this mean? Lots more research needs to be done to kind of elucidate how this affects cardiovascular outcomes. But it's just an interesting thought that it's not just diuresis, it's the quality of the diuretic. So how does the antihypertension effect work? Now, in reality, there's only about a 3 to 4 millimeter drop in your systolic blood pressure with SGLT2 inhibitors, but this is preserved even at lower GFR. So it's not about the inhibition, it's not about the diuretic effect causing lower high blood pressure, because at lower GFRs, there's still an antihypertensive effect, meaning that even if you don't diurese with SGLT2s, you are still going to have a lower blood pressure. So that raised a bunch of work into what is the effect on arterial stiffness. There is something about the way SGLT2 inhibitors affect the endothelial function that may lead to some of these cardiovascular benefits we're seeing. So busy slide, but the big broad strokes of this is that we talked about this column on the right, which is basically the diuretic effect, the plasma volume effect, the endothelial effect, that perhaps this is what improves ventricular loading conditions and leads to better cardiovascular outcomes. There's also an interesting thing that happens to the liver with these, and then that's basically there's an increased glucagon versus insulin ratio, which causes increased fat breakdown and leads to weight loss in addition to glycemic control. So the average weight loss with these SGLT2 inhibitors is something about 6 pounds or so, which is not insignificant. The other interesting thing that was noted with SGLT2 inhibitors is that they prompt the kidneys to increase your EPO, and what that does is increase your hematocrit. So all of these things are nice, but individually or even in conglomerate, they still don't provide a satisfactory explanation why this works as a cardiovascular drug. So, but that being said, there was a kind of gradual evolution to this as being a cardiovascular drug. And that really came from the EMPA-REG trial. This was the first large-scale diabetic trial looking at primarily cardiovascular outcomes. And this was built on the backs of many trials before that, looking at glycemic control and work done in the diabetic era with these drugs. And what they noted is that there was a very significant improvement in primary outcome, meaning lower death from cardiovascular causes, lower death from any cause, lower hospitalizations for heart failure compared to placebo. So this was really compelling that perhaps there's more to this than just glycemic control. And this really prompted the step away from this as just a diabetic medicine. So now we come to the DAPA trial in 2019, which was the first large-scale trial looking at the use of SGLT2 inhibitors in non-diabetic patients. So 40% had diabetes, 60% were without diabetes, and the LVF was about 30%. And it was a large trial with about 4,700 patients. And they were very well medically treated. Now, this was 2019. The big argument here is that there's only 10% on Entresto on the ARNIs. So after I just told you this is the class 1 indication, this was a big criticism in this and said, well, you're not really on the preferred guideline directed medical therapy, but otherwise very well beta blocked, very high. This is, 70% MRA use is pretty standard across clinical trials. And so a well-treated EF about 30. And consistently, the results remained that there was a significant benefit of using SGLT2s versus placebo. This was followed by the EMPEROR reduced in 2020. And the only big difference with this trial is it was a slightly sicker population with an LVEF of 27%, half diabetic, half not diabetic. And the use of ARNIs was double, about 20% in each arm. So the results basically mirrored the DAPA study in that you saw a significant benefit of using SGLT2s versus placebo. The also interesting side notes that were observed is that the rate of decline in GFR was lower in the SGLT2 group. So there's perhaps some renoprotective benefits here. And then they did an interesting subgroup analysis of the ARNI cohort and showed that despite only the 20% ARNI group, that effect still remains. So there was still a trend towards improved outcomes with MPEG versus placebo. So despite the low use of ARNI, the ARNI population still seems to benefit with the addition of this. Serious adverse events, this is what basically a lot of people talk about: the ketoacidosis, the limb ischemia. And if you'll notice, looking at both of these trials, the rate of volume depletion was similar between the two groups. There was no ketoacidosis in EMPEROR and in a few cases in the DAPA. Severe hypoglycemic events happened equivalently in both placebo and MPEG and DAPA. So the important thing to note is that these events only happened in diabetic patients. Remember, there were still about half diabetic patients. So that may be the subgroup that you want to be careful about. So it probably has not much to do with the DAPA or the MPEG, but rather that the other hypoglycemic agents that these diabetics are on. Lower limb amputation, again, almost all in diabetics. The thing that we talk about mostly with our patients is that there is a much more significant rate of genital tract infections, mainly yeast infections, that occur with the SGLT2 use. But again, this is really reserved for diabetic patients. And again, the idea is that if you're a diabetic patient, you are going to have a greater diuretic effect. You're going to have greater glycosuria because the effect of the diuresis really depends on your blood sugar concentration. So somewhat intuitive that those are the patients that would have issues with these. Okay, so that's where I'm going to end on the SGLT2 inhibitors, but I hope that you've been convinced that this is a 4-drug regimen, including SGLT2 inhibitors. There's a lot of things that we don't know about SGLT2 inhibitors on the mechanism of why they protect so well in cardiovascular disease with and without diabetes, but it's a vital addition in addition to ARNIs, beta blockers, and Spiro. This is class 1. This is level of evidence, and it has to be part of the HFrEF regimen. And with that, I'll end and pass it over to my colleague, Dr. Shin, to talk about the role in HFpEF.
Great, thank you, Sandhya. Can you hear us there?
Yep.
Okay, perfect. That was perfect. Audiovisual came also across very well. Are there any questions from the audience for Dr. Murthy, who is broadcasting from NIAC, where we have a heart failure center also? You live in Rockland, you can save the Tappan Zee Bridge toll. You can see her there. Unless you need an elevator or a transplant, we still have to come here. Any questions? Yeah.
I'm having trouble listening to the question. I'm not sure.
I will repeat the question.
Okay, great. Yeah.
Just repeat contraindication.
For if you want to ACE inhibitor, that would contraindication.
Yes, so that's a great question, Sandhya, which I always struggle to answer, by the way, but I'm going to ask Dr. Murthy, who's much smarter. Why is an ANI that contains an ARB contraindicated in somebody who had angioedema to an ACE inhibitor?
Yeah, so there is a greater bradykinin effect with the ARNI than there is with an ACE inhibitor. And that's why, because the neprilysin part of this is actually blocks the breakdown of bradykinin as well. So it's not just the ARB part, but it's the bradykinin that's blocked by the neprilysin. Neprilysin is an enzyme that does a lot of things. Not only does it block the breakdown, but it also blocks the breakdown of bradykinin. So those, if you've had angioedema to an ACE inhibitor, it's a little bit unpredictable on how much bradykinin is going to be blocked with the neprilysin part of this, which is why you would use an ARB where it doesn't affect that bradykinin pathway. So it's not about, you can use, if you've had angioedema with an ACE inhibitor, the rate of angioedema with the ARNI was unacceptably high. And this was from the original and ARNI trials that predated the current version, the current LCZ molecule. And so it has to do with the level of bradykinin that's blocked by neprilysin.
Okay, that was a great answer. Tony McCongo, actually, I know is listening from White Plains right now, and he asked me that question 2 weeks ago, and I said I didn't know. But now this is recorded on YouTube, so I'm going to study this. And Tony, I hope you heard Sandhya. Otherwise, I will just that's my answer. Sandhya, terrific. So we're going to switch. Oh, Dr. Patel has a question.
This is maybe. Hi, Sandhya. That was a great presentation. This is maybe a question that we don't know the answer to. Is there a dose effect response with SGLT2?
Yeah,
I know that the trials usually look at 10 milligrams of DAPA, but sometimes we start lower, and should we be obliged to increase it?
You're absolutely right. We just don't have the data yet. And, I guess, that is a very important question, because the role in, the doses in diabetics are different than what we use in heart failure and what has been studied in the trial. And I'm not aware of any ongoing trials looking at dose effects.
Okay, terrific. Sandhya, thanks so much. I know you're coming down now.
Hey, see you guys shortly in person.
Yes.
Take care.
Let's switch the presentation to here. And then the next speaker is Dr. Julia Shin, one of the original partners, who will speak to us about SGLT2 inhibitors, because that's a hot topic. By the way, SGLT2 inhibitors are now on formulary at Montefiore, so you can use it for inpatients also. Ideally, patients will leave it. There are a lot of issues with insurance, pre-approvals, so that's something you have to speak to the patient about if you prescribe it, and they may run up against issues on the outside. But we can help them after they're discharged also. So HFrEF is the opening lecture. Of course, HFpEF is just about as common. And so Dr. Shin is going to talk to us about specifically SGLT2 inhibitors in heart failure.
Thank you. Yes, thank you. So continuing the bandwagon of SGLT2 inhibitors, and this time as it pertains to heart failure with preserved ejection fraction, I have no disclosures except Sandhya, I think it's tomato. I say empagliflozin, and you say empagliflozin. It's all pretty much the same. So I think if we're talking about HFpEF, the first question to ask is, what exactly is heart failure with preserved ejection fraction? It is defined as signs and symptoms of heart failure with an LVEF greater than or equal to 50%. HFpEF tends to be kind of the forgotten child in heart failure, but it is rising in incidence and now accounts for more than 50% of all heart failure cases, with outcomes that are comparable to those with HFrEF. Women with HFpEF tend to have more symptoms, more dyspnea, more diastolic stiffness, smaller LV size, and higher LVEF when you compare it to men. And HFpEF management really centers around management of the comorbidities that cause HFpEF. HFpEF simplistically is heart failure with an EF of greater than or equal to 50%, but it is a little bit more complicated than that. So not all shortness of breath is HFpEF, and there are some diagnostic scoring systems that help you diagnose HFpEF specifically. So the easiest one is the H2FPEF score. This centers around the comorbidities of HFpEF, and you get points based on which comorbidity you have. So if you are heavy or a BMI greater than 30, you get 2 points. If you are more than 2 antihypertensive medications, you get 1 point. Atrial fibrillation confers you 3 points. Pulmonary hypertension with the PA systolic pressure greater than 35 millimeters of mercury on echo gives you 1 point. Age greater than 60 is 1 point. And if you have evidence of elevated filling pressure by an E to E prime ratio greater than 9 on echo, that gives you 1 point. If you tally all that up and you have more than or equal to 6 points, that is highly diagnostic of having a diagnosis of HFpEF. The HFA-PEFF score is another scoring system. This one's a little bit more complicated, and this one gives you points based on different echo findings and natriuretic peptide scores. So you first do a pretest assessment, looking for signs and symptoms of heart failure, looking at comorbidities. Then you follow that up with an echo and send off natriuretic peptides. And you can see that the scoring system is divided up into functional echocardiographic findings, morphologic echocardiographic findings, and then natriuretic peptide findings in the setting of sinus rhythm and atrial fibrillation. And if you have any of these bolded markers, then that gives you 2 points each, and the non-bolded will give you 1 point each. If you have more than or equal to 5 points, that is highly specific for a diagnosis of HFpEF. Less than 1 means you don't have HFpEF. Between 2 and 4 is the uncertain zone. And when you get into the uncertain zone, you should follow that up with functional testing, such as exercise echocardiography or invasive hemodynamics. The final F2 is if you have other specific etiologies that can mimic HFpEF, such as infiltrative cardiomyopathy, things like that, you would follow that up with either a cardiac MR or endomyocardial biopsy or genetic testing. So if you put this all into a practical algorithm, patient presents to you with dyspnea and or edema. You do an echo, you see that they have an EF of greater than 50%. Then you apply the universal definition of HFpEF. The next thing you need to do is rule out non-cardiac mimics. So are there primary non-cardiovascular entities that can cause these symptoms, such as kidney disease, liver disease, or chronic venous insufficiency? If those are ruled out, you look for HFpEF mimics. Do you think they have infiltrative cardiomyopathy, hypertrophic cardiomyopathy? Maybe they have pericardial disease or valvular disease or high output failure. You would follow this up then with either a cardiac MR, an endomyocardial biopsy, or maybe invasive testing. If you've ruled all these out, you have a diagnosis of heart failure with preserved ejection fraction. And the next step is to identify which comorbidities they have, because treatment will focus around those comorbidities. These are hypertension, diabetes, AFib, obesity, coronary disease, or renal dysfunction. So these are the current approved treatments for HFpEF. You have ARB, ACE, MRA, ARNI, and then most recently you have the SGLT2 inhibitors, the empagliflozin, DAPA, and canagliflozin, and these probably confer a class effect in HFpEF treatment. So Dr. Murthy has already told you what SGLT2 inhibitors are. They're sodium glucose transport 2 inhibitors in the proximal tubule of the kidney that prevent resorption, increased diuresis through an osmotic effect, but do have downstream pleiotropic effects that are very important. Adverse effects, Dr. Murthy also went through. Most commonly, urogenital infections occur. There is a risk of lower limb amputation. Volume depletion is not insignificant. So you have to remember that Entresto can also cause volume depletion through its diuretic effect. So if you're starting both Entresto and SGLT2 inhibitor at the same time, you may want to think about withholding the loop diuretic just so they don't get too dehydrated. Diabetic ketoacidosis can occur in type 1 diabetics. There's also this entity called euglycemic DKA, which is an anion gap acidosis in the setting of a relatively normal serum glucose that can happen. And if you use it in conjunction with insulin, you do run the risk of hypoglycemia. So simplistically, right, these agents increase glucosuria and natriuresis and increase diuresis. However, the pleiotropic effects really come from that delivery of extra sodium to the distal tubule. And by doing that, these medications decrease the renin-angiotensin system. By decreasing RAS activation, you get increased endothelial function, you decrease your blood pressure, increase nitric oxide availability. By diuresis, you decrease preload, right? So you decrease afterload, you decrease preload, you mitigate the reverse remodeling that happens with heart failure. These medications also decrease oxidative stress, inflammation, sympathetic nervous system, and they also induce a mild ketonemia. So by shifting the fuel source of the heart to beta hydroxybutyrate, it makes for a more efficient fuel source. So what is the rationale then for exploring these medications in the treatment of HFpEF without diabetes? Well, we know that diabetes and HFpEF have very similar pathophysiologic features. They both have endothelial dysfunction, they both have insulin resistance. We know that the mechanistic effects of these medications are seen in patients both with and without diabetes. The diuretic effects are the same, the metabolic effects are the same. We also know that cardiovascular benefits of SGLT2 inhibitors are largely independent of glucose levels. If you want to then focus on HFpEF, the rationale for studying these medications becomes even more obvious. So in HFpEF, you have these comorbidities of hypertension, diabetes, obesity, CKD that worsen the whole pathophysiologic process by increasing oxidative stress and inflammation, increasing fibrosis, hypertrophy, decreasing nitric oxide bioavailability and protein kinase G signaling. All of these lead to worsening diastolic dysfunction. Well, guess what? SGLT2 inhibitors treat hypertension. They decrease your blood pressure. They clearly treat your diabetes. They make you lose weight, treat your obesity. And they have a clear renal protective effect as well that is independent of the cardiovascular effects. So you treat the comorbidities of HFpEF and you decrease oxidative stress, decrease inflammation, fibrosis, hypertrophy. You increase your nitric oxide bioavailability and PKG signaling. And this all confers improved diastolic function. So you have a clear rationale for studying these medications in HFpEF. And they did just that in Emperor Preserved. So this was published in the New England Journal in 2021, looking at empagliflozin versus placebo. They enrolled about 6,000 patients with an EF of greater than 40. And they found that empagliflozin had a statistically significant decrease in the primary endpoints that was driven mainly by heart failure rehospitalization. And the results were similar in both diabetic and non-diabetic groups. This was followed up by the DELIVER trial that looked at dapagliflozin in heart failure patients with mildly reduced and preserved ejection fraction. Again, about 6,000 patients with an EF of greater than 40%. And they found a very similar reduction in primary endpoints, driven mainly by reducing heart failure rehospitalization, although there was a statistically significant decrease in death from cardiovascular causes. And if you stratify this by EF, the results were similar if your EF is greater than 60 versus less than 60. And the results were also similar in both diabetic and non-diabetic groups. So based on these trials, ACC-AHA says first-line treatment for HFpEF is an SGLT2 inhibitor. As soon as you have a diagnosis of HFpEF, unless they have a contraindication, you start DAPA or EMPA. These other medications are add-ons as needed. So if they are volume overloaded, you would add on a loop diuretic or an MRA. They should also get ARNIs, and if they're ARNI ineligible, they would get an ARB. This is the most recent 2023 ACC guidelines. There is a suggestion that if you start SGLT2 inhibitors earlier, you confer a greater benefit. So if you look at this trial that looked at EMPA compared to placebo, you see very early on in the trial, at 45 days, you confer a benefit in heart failure rehospitalization. At 30 days, a decrease in cardiovascular death. And if you look at the Kaplan-Meier curves, you see they split out very early. So as soon as you have a diagnosis, you should start these medications. In fact, there's a suggestion that you should start them in the hospital before they go home. So the Soloist WHF trial, this is looking at sotagliflozin, which is an SGLT2 and 2 inhibitor, not yet FDA approved, found that if you start this medication either shortly before discharge or shortly after discharge, you have a decrease in death and hospitalization. This is regardless of EF. MPulse also showed the same thing. So if you start EMPA in the hospital, they get better diuresis, and they have improvement in the clinical outcomes of death and heart failure events. And this is, again, regardless of LVEF. So in conclusion, SGLT2 inhibitors and HFpEF should be first-line therapy. They improve quality of life, cardiovascular mortality and hospitalizations in HFpEF patients. They improve endothelial function and decrease myocardial fibrosis. They're effective in both diabetic and non-diabetic populations. There's a significant renal benefit in addition to cardiovascular protection. It's an easy medication to give. You give one pill, one dose, start 10 milligrams of DAPA or EMPA, and there are a few interactions with other drugs. You should start these early because benefits are obtained in a very short period of time. So follow the ACC guidelines. Start DAPA or EMPA 10 milligrams daily with the diagnosis of HFpEF unless contraindicated. Thank you.
Any questions for Dr. Shin? Yeah. Don't be shy. Don't be shy. This probably, I have to say that the lectures of medicine, you always come to see the cool new toys and everything, but this has really the biggest impact. And SGLT2 inhibitor in addition to our standard armamentarium is probably what's going to save the most lives in the next year, even though we're going to show you amazing data on transplant Albert and all that. So this is really where the money is. If you're practicing and you don't prescribe it, you're not doing well, and your patient won't. So this really is where the money is. So questions, yeah?
Oh, thanks, Julia, for good talk. I was wondering, they always asked, and one of the issues with the HFpEF trials always was the heterogeneity of the patients that they enrolled, meaning what actually defines HFpEF. And I always meant to, but never did, was compare the patients that they enrolled in the SGLT2 trials compared to previous trials. Did they do a better job of phenotyping these patients? And maybe that's part of the reason we saw a benefit. I don't know if there's an answer to that.
Do you mean by like comorbidities?
Well, just what exactly defines HFpEF? And
Yeah.
you know, if you put somebody with COPD and has some right heart failure, maybe it's not going to have the same benefit as somebody who has hypertensive HFpEF.
Yeah, no, I agree with you. I don't think that they were as granular as that. But what I did try to do was going through the trials, HFpEF is defined as EF greater than 50, right? These trials enrolled EF greater than 40. So there's that mid-range, heart failure patient, and then there's the true HFpEF patient. And if you stratify those out, the benefits are actually very similar, right?
Yeah, Joe?
Hi, great presentation. I would like to ask regarding the indication of MRAs and RNAs for patients in HFpEF. The trials kind of were not significant from a statistical point of view, but I see the Americans are given this recommendation. I know the European guidelines don't. So are you using it in your regular practice, or do you kind of stratify according to congestion, for example, for MRAs, or, if the patient's hypertensive, well, he's obviously going to have it anyway. And are you shifting them to RNAs instead of just a normal ACE or ARB?
Yeah, so the newest guidelines from the ACC say that these are secondary if you have the indication. So an MRA would be if there's evidence of volume overload. The ARNI, they give it a 2B indication in all patients with HFpEF. It's definitely not as strong as the SGLT2 inhibitors are given. So.
Great. Question actually from Dr. McCandle from White Plains, whether SGLT2 inhibitors affect the incidence of atrial fibrillation.
I do not know the answer to that.
Yeah, I think actually there is some preliminary literature that shows that, but nothing that has been prospectively evaluated. Great question. Joe has the answer. Dr. Gonzalez from
no.
Barcelona.
No.
Thrown in
They
left.
do reduce ventricular arrhythmias, so maybe.
Okay, very good. For HFpEF, I think the question that Sneha asked is very important. What is HFpEF, right? We're going to later on talk about device therapies for HFpEF. And in those studies, the phenotype is actually much better defined because people are having a right heart catheterization, and then we exercise them. And we, of course, have our very own lab right here for heart failure. This is something, if you see patients that you think have HFpEF, you should really refer them for right heart cath with exercise to really study their physiology and maybe find out that they don't have HFpEF, that they have COPD or it's simply obesity. So I think this is going to come in future guidelines because HFpEF right now is a bit of a wastebasket. Anybody who has an elevated BNP level and a normal ejection fraction. So more to come. So this was a great session. Thanks, Julia. Thanks, Sandhya. We're going to switch to the next session. I forgot who's chairing this. Whoever is chairing this knows. Please sit at the desk. And then we're going to have Aldo Chinon, who is going to take the role, even though he's an overall cardiologist who knows everything. His true expertise from our perspective is imaging, hypertrophic cardiomyopathy, especially MRI. We go either to Dr. Chinon or Dr. Slipchuk, who's also going to join. The theme is something we haven't done before. We're going to try to relive our clinical practice in complex cases, where it's not just one of us looking at something and making decisions, but rather we play off our strength and talk to each other and try to figure out the case. So Dr. Torres, who's the director of the amyloid clinic, is going to, discuss with Dr. Chinon a case of amyloid and how to diagnose it and how to treat it. So we're just going to wait. We have to blah, blah for a few minutes because we're going at 9 o'clock, just in case the YouTube channel, I don't want to, take the YouTube channel off track. So what I can do in the interim is Dr. Patel, who is the director of our transplant program for the past 3 years, has kind of taken over from me. And initially we had some serious concerns about this, but we just got email this morning. I don't know if you know the SRTR registry that monitors nationally outcomes of heart transplantation that are mandatory to report. And we just got a report. This is going public in about a week or so. It's kind of public among centers, not a secret, that the 1-year survival in the United States this year is reported at 91%, and that the survival of heart transplant patients at Montefiore is 96%. And it's all-time high. So bravo to the whole team. I'm going to accidentally mention this several times throughout the day. And of course, Dr. Patel tomorrow is going to give a lecture on state-of-the-art heart transplantation. But this is a huge win with where we are with our program. This is the best result ever. And I think competes with anybody in the US. So that was a time filler, a very nice one.
Yeah, great.
So I think we're going to go ahead and talk about amyloidosis. Jim?
Okay, thank you, Dr. Yordi. So my name is Jim Torres. I'm a Montefiore cardiologist, and I see a lot of amyloid patients. So we're going to run through, I'm going to give you a very brief, broad-based review of cardiac amyloidosis, as well as a review of kind of contemporary drug development that's going on right now in ATTR cardiomyopathy. And Dr. Scanoni will be giving a few slides on advanced cardiac imaging specifically related to cardiac amyloidosis. So we'll start with a case. So these are disclosures. Start with a case. So this 65-year-old man, he presents to Montefiore emergency room with new onset heart failure, JVD max, Ralls, S4, hepatomegaly, lower extremity edema to the thighs. And it's very straightforward. He has no cardiac history or any medical history because he hasn't seen a doctor for 40 years. He takes no medications. And so let's look at the review his EKG and his echo. So his EKG is relevant for normal sinus rhythm, first degree AV block, extreme axis, IVCD, and this is his echo. Okay, so it's interpreted as moderate to severe concentric LVH with a normal ejection fraction. So we see patients like this every day at Montefiore in every hospital in the world. This is a 65-year-old man with new onset HFpEF. So we have a pretty standard differential: hypertensive heart disease, amyloidosis, hypertrophic cardiomyopathy, sarcoidosis, Fabry's, plaquenil toxicity, which we're seeing a lot more of, and I think we have to talk about next year at Bronx Heart or MonteHeart, hemochromatosis, idiopathic restrictive cardiomyopathy is pretty standard differential. So amyloidosis is basically the extracellular deposition of misfolded circulating proteins that causes damage in end organs. There's two major precursor proteins for cardiac amyloidosis. They're TTR and immunoglobulin light chains. The immunoglobulin light chains, they give you what's called primary or light chain amyloidosis, and transthyretin can give you cardiac amyloidosis either through wild type or mutant transthyretin. So briefly, light chain amyloidosis is from misfolded immunoglobulin light chains from a monoclonal expansion of plasma cells in the bone marrow. It's a very aggressive form of cardiac amyloidosis with mortality typically expressed in weeks to months if left untreated. So making the, basically making awareness and the diagnosis and treatment has to be done quite quickly and effectively. Treatment is basically going to be down kind of like a multiple myeloma type pathway. So things like Cybor-D or bortezomib-based treatments, as well as the CD38 monoclonal antibody daratumumab. TTR cardiomyopathy is from misfolded circulating TTR, which is typically going to be mostly from the liver. This causes basically two major syndromes. There's a cardiomyopathy syndrome and a polyneuropathy syndrome. There's over 100 mutations that cause. That's better. Now I can hear myself really well. Okay, so if you missed most of that, it's okay. Everything else is still really good. So anyway, there's over 100 different mutations causing cardiomyopathy or causing polyneuropathy and cardiomyopathy. But the one that's important and was most relevant to working in the Bronx is this V142 isoleucine mutation. This is the one that's most common causing cardiomyopathy and is seen in 3 to 4% of African Americans. Typically, we're talking about a population that's older and typically greater than 70 years of age. The youngest patient that I've seen with meaningful cardiac amyloidosis from V142 isoleucine, though, is 50 years old. So it is possible that it can involve people with middle age as well. Typically, we're talking about a more indolent course with a mortality more like months to years if left untreated, and the treatment modalities we'll discuss later in the lecture. So the standard cardiac manifestations of cardiac amyloidosis: increased LV wall thickness, heart failure, conduction abnormalities, bradycardia requiring a pacemaker, atrial arrhythmias, and intracardiac thrombi. But we'll keep in mind it's a systemic disorder, so there's non-cardiac findings as well. So the most common extracardiac manifestations are connective tissue things such as carpal tunnel syndrome, spinal stenosis, trigger finger, rotator cuff syndrome, and asymptomatic bicep tendon rupture. Oftentimes patients will have polyneuropathy as well as autonomic dysfunction, orthostasis, GI upset, and erectile dysfunction. And now Dr. Scanoni is going to discuss some aspects of imaging.
Yeah, I think the first point that we want to just make is that you see that echo in a patient you have HFpEF. You know, we have to be thinking in, can my patient have something more than just HFpEF, right? So, and amyloid is a big one. And we know from data that about 10% of patients that present to us with HFpEF actually can have underlying, cardiac amyloidosis. So what I want to start with is, I think, taking this approach more from an imaging perspective. So when we get this patient with HFpEF and we get the echo, and how we can, evaluate this patient, and what are the imaging targets that we can use to try to diagnose, our patients. And the first thing is the electrocardiogram. And I mean, typically in traditional, we have said low voltage, but I think one key point that I want to make here is that it's a relative low voltage. So you can still have high voltage or normal voltage, but you have to compare that to your wall thickness. And if you have a relatively low voltage, that's something that is very suspicious. The second thing is from an echocardiogram. I think that, what we can see, as we all know, is just increased wall thickness, which tend to be concentric, restrictive kind of pattern of LV filling. From an MRI perspective, we can still see those changes, maybe a little bit better, with the added value that we can see either scarring or infiltration of the myocardium, which tend to be diffuse, and with expansion of the extracellular space. as the amyloid deposit in between the cells. So the extracellular volume naturally is going to expand, and that's something that we can nicely see with the MRI, although it's very hard to discriminate between the different types of amyloid. And finally, the other target is just actually the amyloid compound itself. We can have either tracers with radionuclide imaging that can target the amyloid compound or the individual elements of the amyloid deposition. Traditionally, we have been using SPECT with the paraphosphate scanning, particularly for ATTR cardiac amyloidosis. We're going to talk a little bit about that. Now there's like the expansion and the field is very evolving very rapidly with new tracers, particularly on the PET side. That's going to help, early diagnosis, better prognostication, and even, follow up in terms of treatment. So just go over a little bit of, to expand on the echocardiogram that we see. I think that these are kind of the important things that you're going to be looking for in not only the increased wall thickness that, often we see that also involve the right ventricle. There's also deposition within the cardiac valves. You're going to be that have thickening of the valve. And one particular population that is very often identified with cardiac amyloidosis, particular ATTR, is when you have these patients with paradoxical low flow, low grade AS. You tend to have the typical restricted pattern in terms of LV filling. Not all of them have it, so you still need to kind of do your kind of diastology. Of course, at the end of the spectrum, we see this kind of typical grade 3, restricted filling. One thing that is very important, is very useful, is the use of strain imaging, and with the typical cherry on top and then the apical sparing, is that something that can help us differentiate if we're in presence of amyloid as opposed to hypertensive heart disease, hypertrophic cardiomyopathy, or even hypertrophy from aortic stenosis. There's new data emerging about the use of left atrial strain in predicting actually stroke in patients with amyloid, that we know they can stroke even in the absence of atrial fibrillation. And you can see here, in display, like the different features that we just, mentioned. Again, a little bit more on the apical strain. I think you can see here on top, you can have the nice, cherry on top, which should signal the presence of amyloid, or at least initiate the work for that. But this is not only important in terms of diagnosis. I think this is important in terms of prognosis, as you can see here. One caveat is that, again, the data in which this was tested was against hypertensive heart disease, aortic stenosis, and hypertrophic cardiomyopathy, some observational data. But I think there's some other cases like oxalosis that can give you the same pattern. So you have to keep your differential very, very wide. So in terms of MRI, again, MRI can just identify or suggest the presence of amyloidosis, and mainly based on the presence of diffuse endocardial scarring with LDE, which is kind of very, very typical with high and marked elevations in the extracellular volume. One key feature here is that, as you can see here, normally the blood pool should turn black first. That's normal because there's more gadolinium in the blood pool. In this case, we're seeing that the myocardium is turning black first before the blood pool. So that signals there's a lot of scarring, capturing the gadolinium in terms of the myocardium. That's a typical feature of amyloidosis. I think it's important that, when you analyze MRI, you keep your differential broad. And we just have like a patient probably 3 weeks ago in which we did an MRI with kind of typical pattern. And working with Dr. Rolani, we said, well, what are the differential? The patient was in hydroxychloroquine, and in fact was actually hydroxychloroquine toxicity. So keep your differential open, and when you're looking at these patients with MRI suggestive of amyloid. And ATTR, I think PYP has been revolutionary, and now kind of very much we can diagnose, in some selected cases without the need of biopsy. I think it's important that it's highly specific and sensitive when you have the typical morphologic changes and in a patient that has no blood dyscrasia. And that's important to mention because then we know that 25% of patients who happen to have positive PYP can have AL cardiac amyloidosis. So I think it's important that you ordered the PYP and the light change and UPEP and SPEP at the same time, because this is very important for interpretation. Keep in mind that the only way you're going to say it's a positive test is that you have uptake localized into the myocardium. So we're way away from planar imaging, in which you can be full from blood pool, and we need to do SPECT and demonstrate that the uptake is actually in the myocardium. Be aware of some variants of ATTR that can actually be, negative, depending on the fiber, and of course of potential, differential that can still give you positive PYP, which you can see it on there with MI or hydroxychloroquine toxicity. So with that, this is a review. I'm just going to give back to Jim.
Great. So thank you, Aldo. It's a beautiful review of the cardiac imaging and cardiac amyloidosis. So this is, as I say, no amyloid talk is complete without a diagram of the diagnostic pathway of cardiac amyloidosis. It usually makes my head spin a little bit. So I'm going to distill it into the most important points on the next slide. I would reference you to this 2023 ACC Expert Consensus Decision Pathway. It's a brand new document and I have to say quite well written and a great resource. So your workup, if you don't think about the diagnosis, you'll never make it, right? So you have to have a clinical suspicion and some certain red flag signs and symptoms, particularly carpal tunnel syndrome, spinal stenosis, typically older patients, African Americans, what I call cryptogenic heart failure. They have heart failure and you can't figure out for the life of you why they have it. The workup's going to entail three different things. So it's going to be a technetium pyrophosphate scan. And as Aldo said, we are always going to do that in conjunction with assessing for a monoclonal protein. So it's going to be SPEP with an IFE, UPEP with an IFE, and plasma-free light chains. In the case, we'll discuss this a little bit more. And then in all these patients, you'll get TTR genetic testing. If with that workup, I'll just tell you, in 95% of the cases, you'll have a very definitive answer. You'll know exactly what's going on with the patient. About 5% of the cases, you are not going to know because there'll be conflicting information. And so in that case, you're typically going to need to make a biopsy, cardiac or other affected site. In my case, it's typically a cardiac biopsy. So back to our patient, 65-year-old guy with HFpEF. This is this technetium pyrophosphate scan, and you see amyloid uptake in the myocardium on SPECT imaging. So assessing for the monoclonal light chain, you see he has a kappa predominance and a high kappa to lambda ratio, suggesting that he has a monoclonal protein, that's clonal expansion. There's nothing on the UPEP. The UPEP is bland, but on the SPEP with the IFE, he has an IgA kappa band. And his genetic test is a V142 heterozygous. So this is the legacy V122 isoleucine mutation that you see so frequently in African Americans. And it turns out this patient is African American. So what do we have? So his workup, he has evidence for TTR. He has a TTR mutation, but he also has evidence of a monoclonal gammopathy. So what kind of cardiac amyloidosis does he have? Light chain, TTR, both, or neither, right? There's one wrong answer, and that's neither. But as of right now, it could be any of the first three. So what's the next best step? Well, we ended up getting a bone marrow biopsy, and it showed basically he has an MGUS. So he has 6 to 9% atypical plasma cells in the marrow and no amyloidosis in the bone marrow. So we did an endomyocardial biopsy. It was demonstrated on histology, Congo red stain consistent with amyloidosis. So this specimen was sent to the Mayo Clinic for mass spec analysis and ultimately confirmed ATTR. So this is again done with the ATTR cardiomyopathy with coexisting MGUS. So some therapeutic strategies. To understand therapeutic strategy, you just have to understand the natural history of the TTR molecule. So everything starts in the liver. I have a pointer here. If you see this, everything starts in the liver, which produces the TTR molecule. If the TTR molecule is unstable, it will unfold and dismember and ultimately wind up being fibrils in the heart. So there's several ways we can try to prevent that from happening. The first thing we can do is what's called TTR knockdown, and that's preventing the production of TTR molecule. There's two drugs that are available commercially right now for the polyneuropathy version of TTR, not for cardiomyopathy, at least as of right now. And they're RNA inhibitors. Okay, so these are gene silencers, and what they do is they block the translation from the mRNA to the protein of TTR. And they typically will do that in about 85 to 90% pretty reliably with what I would characterize as a pretty good safety profile. Another version of doing this is CRISPR-Cas9, which I'll discuss a little bit later in the talk. Okay. The next thing you can do is you try to prevent the breakdown of TTR. And so what they have is what's called TTR stabilizers. Tafamidis is FDA approved for this. And basically it's a structure-based drug design. that has a drug that goes into the binding site of the TTR, prevents it from breaking down. And ultimately, the last thing is this idea of fibril removal. So when I think about amyloid in the heart, I think like this gunk in the heart, like how could it possibly come out? How could you have how could you possibly remove that? But there's now increasing data that perhaps some monoclonal antibodies can do that. We'll discuss this a little bit later, as well as this might be happening naturally in all of our bodies as well. So briefly, tafamidis, the evidence supporting tafamidis is from a large-scale randomized controlled trial with an absolute risk reduction of all-cause mortality of 13% that you can see here. Okay, it basically has a favorable safety and side effect profile. It also attenuates the worsening of KCCQ and 6-minute walk tests. Okay, so currently the only FDA-approved treatment for ATTR is tafamidis. It's a TTR stabilizer. It has mortality and nominally kind of a functional benefit. So the good thing is it stabilizes the disease, but it doesn't reverse the disease process. So I can tell you there's a big problem. So when you talk to the patients, they're very happy to hear about stabilizing. They're not too happy to hear about not reversing, right? And they'll always ask me, when I take this tafamidis, is it going to make me feel better? And I have to, as artfully as possible, say, well, not really, right? So it will make you live longer. It will prevent you from getting worse, but it's not going to make you feel better per se. And I think that's a great opportunity for drug design. So the paradigm is evolving and evolving quite rapidly. So what I have listed on this table, at very least, is all different drugs that are in phase 3 or beyond in terms of drug development. So patisiran is an RNA inhibitor. It has phase 3 randomized controlled trial data supporting its use as a functional benefit, no mortality benefit. It's in front of the FDA now, and we may or may not hear about approval sometime in the fall. Patisiran is a very similar RNA inhibitor. HELIOS-B is a large-scale phase 3 randomized controlled trial. Enrollment is complete with more conventional cardiovascular endpoints, such as cardiovascular mortality and heart failure hospitalization. So we'll hear about the results of that in a year or two. AG10 is a more potent TTR stabilizer, very similar to tafamidis. And this is attribute cardiomyopathy. This is the one that I'm the site PI here at Montefiore. It's a phase 3 randomized controlled trial. It's complete now, and the results will come back this fall. And then there's this other RNA inhibitor, eplontersen, also in a large phase 3 randomized controlled trial with cardiovascular endpoints. Trial's ongoing, and we'll know the results in a year or two. There's some also early phase study, CRISPR and recombinant ATTR. So this is the latest and greatest, very interesting things going on. So CRISPR-Cas9 has phase 1 data from the New England Journal, 6 patients, 1 dose of the CRISPR complex, and that's it. Okay, and it causes a frame shift mutation of TTR genes, both wild type and mutant, in the liver, creating a TTR knockdown of about 85%. And just a couple of weeks ago, for the New England Journal, phase 1 data on the anti-TTR monoclonal antibody is a recombinant human monoclonal antibody to misfolded, though not circulating, ATTR. And this demonstrates safety and some suggestion of ATTR regression via CMRI and technetium pyrophosphate scanning. So finally, our patient, the final diagnosis is ATTR cardiomyopathy. He enrolled in our clinical trial here at Montefiore for AG10, and he's doing well. He's now actually in the open label extension, doing very nicely. So, it's a systemic disorder, and so you need an interdisciplinary team approach. We have a lot of expertise here at Montefiore. There's too many to name individually, but you see we have quite a lot of expertise in cardiology, hematology, pathology, and genetics. And here's my contact information should you wish to refer patients or you have any questions. That's the end of my talk. I hope you have a great day here at MonteHeart. Thank you.
Thank you very much. Can you hear me? Thank you very much, James and Aldo, for the amazing presentation. I'm Leandro Slipchuk, and I'm co-chairing with Rosita Roslani. Rosita Roslani, that is the director of the sarcoidosis clinic, and I think we have a few minutes or 1 minute or two for questions. I'd like to start with the first question, Dr. Roslani.
Thank you, Dr. Torres. That was a great talk. One question that I think we run into clinical practice for patients who have this genetic mutation, the valine 142 isoleucine, what do you recommend for their family members? How do we, screen them? Should we screen them?
That's a great question. Okay, so we're having some mic issues, so I don't know if everybody heard that. The question is, if you have somebody who's affected the V122 isoleucine mutation, how do you counsel? Oftentimes they're older and they come with oftentimes their daughter, right? Or it's one of their children. And how do you counsel the child? So basically, I think important things to remember is that it's autosomal dominant transmission, which means a flip of the coin. Okay, so assuming the patient is heterozygous, the chance of every kid getting it is 50-50. Okay, so say you're unlucky and you get it, then the question is, what's the penetrance? And it turns out the penetrance would appear to be relatively low, so that's a good thing. So it's a somewhat controversial point, but generally it's thought that the penetrance is low, so most people who get the gene are not going to get the disease. Beyond that, I recommend that they be alert to all these red flag symptoms, carpal tunnel syndrome, spinal stenosis, heart failure, and problems like this. And then they can get genetic tested if they'd like. You have to keep in mind that could be a findable issue for them, at least in the US, in terms of getting life insurance. Okay, health insurance is protected by law, but life insurance is not. So if you're totally well and you're 25 years old, you may want to put that off. There's really no rationale that you'd need to get tested at that age. But once you're older, if you have other comorbidities, it's probably okay.
Yeah, I just want to make this, I think, a critically important point. For me, we're seeing also, of course, a lot of TTR amyloid patients, older patients in NIAC and in White Plains, so we're happy to see them. And I have to say, I struggle with treating an 87-year-old person with a drug that is very expensive. But I have to say, I learned a lot about this, and I've recognized how important it is to make the proper diagnosis. And I almost feel like I'm not treating just this patient who's 87 and who has diastolic heart failure and who may not make it to 100, but I'm treating the whole family. And you mentioned briefly, and we may have time later, there's now CRISPR technology and there's antibody therapy. So I believe, 5 to 10 years from now, we will be able to reverse this and cure this. So I think at that moment, it's very important that a 25-year-old knows that he or she has it. So, and that's kind of my message to the patients that I see. This is super exciting, a lot going on, and I'm sure being the CRISPR, the antibody studies here at Montefiore, in which case they will come to Jim, but we can see patients and treat regular TTR amyloid at any of our locations.
Thank you for that answer. So we'll move now. We'll move now to the next lecture, that it will be cardiac sarcoidosis, and it will be a team approach to complex clinical scenarios, and it will be Dr. Roshnani and myself.
Okay, actually. Just make a mic check for a second.
Can you hear me?
Project, I think we can hear you well, and keep a good distance to the mic.
Can you hear me? Okay. All right. I'm having.
Not great. Then just use the mic, but hold it. The hand mic.
I'll try to speak louder. Yeah. I do need to change this presentation up also, because this is the old one.
So nobody can see what you're doing.
Yeah. Oh, you can see it there. Shows up.
It's good. I threatened to. From after the initial draft, I will. If do what and by 5. Yeah. Oh, no, doesn't matter. No, you're here as international expert.
Okay.
Say again? What?
For the fam.
Restrictions, I mean.
Good morning, everyone. I apologize for the delay here. Dr. Slipchuk and I are going to tag team here and talk about an interesting case scenario that we dealt with over the last year or so that kind of highlights the nuances with inflammatory cardiomyopathies and the team approach that you need to take care of these patients. So here is the case. This is a 48-year-old woman who presents with 1 week of dyspnea, orthopnea, and palpitations. Basically presents with new onset heart failure. She has a history of hypertension, which is well controlled on losartan, and pre-diabetes or diabetes, for which she takes metformin, but the A1C is good control. On exam, she's afebrile, she's tachycardic, hypertensive, has bibasilar crackles, and her chest X-ray shows pulmonary edema. This is her electrocardiogram that demonstrates sinus tachycardia with lots of APCs, VPCs, and a new left bundle branch block when you compare it to her old electrocardiogram that she had with her primary care doctor about a year ago. So we start working her up. We give her diuretics to make her feel better, start working her up. And this is her echocardiogram. I'm going to have Dr. Slipchuk walk us through this echo here.
So if you play, so we can see on the left, the fourth chamber, in the middle, the short axis, in the middle, the short axis, and the two chamber on the right. We can see that the EF is severely decreased. Let's see if this plays. Severely decreased, and the important thing is that the RV function is preserved, and there is significant segmental wall motion abnormalities. So that should raise some differentials already in our mind that we'll go through.
So here we have a 40-year-old woman who comes in with new heart failure, has an echocardiogram that shows severe LV dysfunction, regional wall motion abnormalities. And while she is being optimized from a heart failure standpoint, on day 3 of her hospitalization, she develops complete heart block for 10 seconds on telemetry. She also has periods of transient AFib. And the question now is, what do we do for her? How do we work her up? What are the differentials that we're thinking of? And what would be the next steps in her workup?
So it's important, right? When we have these wall motion abnormalities, we should always think about CAD first in the differential, but some other things that should come to our attention are also sarcoidosis, arrhythmogenic cardiomyopathy. And these are hard to differentiate just by echo alone. So next.
So yeah, so exactly going down that path of looking at ischemia. Is this ischemia? Is this inflammation? Or is this an inherited cardiomyopathy or arrhythmogenic cardiomyopathy? We started with an angiogram, and she had normal coronaries. So the next step then to look for an inflammatory process versus a genetic inherited cardiomyopathy was advanced cardiac imaging, and that's exactly the route we went down.
So we started here with the cardiac MRI. As we can see on the left, we can see the T2 weighted images and the four chamber on the left and a short axis on the right. And here we see a hyperintense edema. We see it in the lateral wall and a little bit in the basal part of the anterior septum. On the right part of the screen, we can see the late gadolinium enhancement images. And we also see a transmurality with a subepicardial predominance on the lateral wall. And we can see that this late gadolinium enhancement is patchy and also involves the basal part of the anterior septum.
So we have an MRI that kind of supports our suspicion for an inflammatory process. But how would we confirm this? How would we decide whether to treat it or not?
So the next test that we did here, so we have the diagnosis higher in the differential here probably would be sarcoidosis. So we decided to go ahead and do a PET scan. So in the PET with the sarcoid preparation, where the patient has to do a diet for 48 hours that is high in fat and low in carbohydrates, we can see on the top of the images, we see the perfusion and we see a perfusion defect on the lateral wall. And then on the part that we suppress the uptake of the myocardium, we see that there's a metabolic activity still on this lateral wall and a little bit in the basal anteroseptal wall. And this tells us that there's active inflammation in the area.
So based on the MRI and the PET, do we have a diagnosis now? Should we start treatment? I would argue no, because you need a histological diagnosis to call this sarcoid. In our case, what we ended up doing was we did an endomyocardial biopsy that you can see to the right-hand side here that shows a diffuse interstitial mononuclear infiltrate with a few giant cells. And subsequently, this patient also had uptake of FTG uptake on lymph nodes in the chest, and we decided to biopsy the lymph nodes, and the lymph nodes then showed non-caseating granulomas, which are consistent with sarcoidosis. So to talk a little bit more about sarcoidosis before we go back into the case, which now raises the question of, is this giant cell versus is this sarcoid? Let's talk about sarcoid a little bit. So sarcoidosis is a granulomatous inflammatory disease of unknown etiology. Typically affects women more than men, and it's a disease of middle-aged patients, unlikely in the extremes of age groups. The prevalence is higher in individuals of Northern European, African American, Afro-Caribbean, and Japanese descents. In the United States, it's 3 times more common in African Americans than Caucasians. And cardiac involvement is rare. You can see asymptomatic cardiac involvement in about a quarter of all patients with sarcoidosis, but clinically relevant cardiac involvement is only in about 5% of patients. Cardiac involvement does confer a worse prognosis in patients with multisystem disease. So when should you suspect? What are the cardinal clinical manifestations of cardiac sarcoidosis, and when should you suspect this disease? The 3 main clinical features that we should be aware of are unexplained AV block in a patient who's under 60 years of age, where degenerative AV node system disease is very unlikely. Patients with non-ischemic cardiomyopathy with regional wall motion abnormalities, aneurysms, basal septal thinning that are not explained by coronary disease. And then idiopathic VT in patients who don't have ischemic heart disease or any other known cause for VT. And this is based on data literature, which is sparse, but that supports that in patients who present with AV block under age 60, up to 30% of these in registries have been found to have an inflammatory cause for their AV block. And the important thing here also is that these patients have a much worse prognosis than patients who just have idiopathic AV block. So it's important to diagnose this disease. If you look at LVAD and transplant series of patients who had histology looked at after, between 3 and 6% of these patients have in hindsight been diagnosed with cardiac sarcoidosis that was missed initially. And then in patients who were patients with idiopathic VT who were systematically screened, particularly those with non-ischemic cardiomyopathies, up to 15 to 30% of these patients were actually found to have cardiac sarcoidosis. So it's not that rare, but we have to be thinking about it and looking for it. The diagnosis, like we discussed in our case, cannot be made in isolation with just the clinical features or just the imaging features. It requires a combination of clinical features, imaging features, and tissue histology. And the diagnostic criteria that are most commonly used are the Heart Rhythm Society 2014 criteria, which mandate tissue histology that shows non-necrotizing granulomas either in the heart or outside of the heart, and the Japanese Circulation Society guidelines, which actually make an exception for isolated cardiac disease, where you may not have tissue, but there's a bunch of imaging and clinical features that put together that might highly suggest the diagnosis. Advanced cardiac imaging has become a very important tool in diagnosing and managing this disease, and I'll let Dr. Slipchuk walk us through how to decide what tests to do and when.
Thank you. So it's very important here, and we're very lucky here to have many different options for advanced cardiac imaging. But these patients should be probably diagnosed and treated in a specialty center, in a coronary center. So as options, we started with the echo first, and the option is usually to go for a cardiac MRI versus PET. And sometimes we can have both. For example, here at White Plains Hospital, we have a PET MR where we can do both together. That is actually ideal if available. So we can see here work from Dr. Hahnemann in Canada, where they did a meta-analysis that was published in 2022 on the left. And this was a meta-analysis of about 33 studies comparing cardiac MRI versus PET on the diagnosis of cardiac sarcoidosis. In this study, there were 6 that compared them head-to-head, one to each other. And we can see that cardiac MRI in this meta-analysis show a higher sensitivity when compared to FDG PET, but a similar specificity. So what about outcomes? They recently published this year, the same group, a study on outcomes, and they saw that cardiac MRI has a sensitivity of 86% and specificity of 60%, and PET is similar, but a little bit on the lower side. I think it's essential that also, we can't say MRI is the best for every single patient. We have a lot of advanced sequences now to get good quality late gadolinium enhancement, like 2D, 3D, single shot, but it depends a little bit on the patient as well. If they can do breath holds, if they have cardiac devices on the PET side, if they are diabetic, if they can do the appropriate preparation. So that's very important. And work from Chetam Shenoy in University of Minnesota also shows us they did a prior study where they looked at the meta-analysis, looking at the patterns in cardiac MRI that are actually diagnostic for cardiac sarcoidosis. They looked there, patients had a tissue diagnosis of cardiac sarcoidosis, and they found that it's not that any pattern could happen. In that study, they found that the septum is often involved, and it can be patchy. There's often subendocardial involvement, but it's rare that we have just subendocardial involvement or that we have involvement just on the lateral wall. Then they published this study in JAMA Cardiology in 2022, where they look at outcomes actually based on these patterns of late gadolinium enhancement in patients that had proven sarcoidosis. And they found that the heart failure and arrhythmogenic outcomes were higher in patients who had the typical patterns that they found more commonly in patients with cardiac sarcoidosis, involving the septum, usually patchy with subendocardial involvement. And the ones that had the patterns that are uncommon, like involvement in the subendocardium, the lateral wall, actually did better. So the idea is that these patients could have either a more benign form of cardiac sarcoidosis or actually not have cardiac sarcoidosis. And the idea, I think this is very important work by this group. So we try to decrease the amount of studies that are read as probable possible cardiac sarcoidosis. So this gives us an idea of when the patient has it and how to probably select patients for an ICD. So we can see here a possible approach for the diagnosis. So if you have a clinical suspicion for cardiac sarcoidosis, in particular when you have extra cardiac involvement, then you can go for cardiac MRI with contrast. And if positive, in particular if you have the patterns that we just described, we wonder, does the patient have any known extra cardiac sarcoidosis? If they have it, we can go for cardiac PET with perfusion and metabolism. And if they don't, I think this is a little bit more tricky because then we're targeting the isolated cardiac sarcoidosis. So in this way, PET can help us because we can have a whole body PET, and like Dr. Roshlani was describing, we can then find a target to do a biopsy. We can also do a LV biopsy in some cases, but it's a lot higher risk. So if we can target extra cardiac findings, that's better. And then we can also use the PET later on after we start therapy for monitoring of therapy.
Going to management, so it's in addition to how you treat the clinical manifestations, which is GDMT for heart failure, pacemaker for AV block, there's immunosuppression is kind of the cornerstone of treating inflammatory cardiomyopathies, but there's no real guidelines here. There's not a whole lot of data here. So a lot of this is just based on expert consensus. The first line therapy is corticosteroids. Sarcoid responds very well to steroids, but these medicines have lots of side effects. So we frequently will now upfront start a steroid sparing agent so that we can use a lower dose of corticosteroids and start to move towards a longer term steroid sparing agent. There are, of course, third line agents like TNF alpha inhibitors that we use in patients who don't respond so well to steroids and methotrexate or mycophenolate. But I have to tell you that, a lot of this is a moving target. We don't exactly know what works best for these patients. This is a rare disease, and there is one randomized control trial going on right now that's comparing steroids, prednisone, compared to lower dose of prednisone with methotrexate upfront, which is the CHASM study. And we here at Montefiore are an enrolling site for this randomized clinical, international multi-center randomized clinical trial. In addition to immunosuppression, another thing to be cognizant of in these patients is the risk of arrhythmias and sudden cardiac death. Now, the risk of arrhythmias in patients with cardiac sarcoidosis is much higher than other non-ischemic cardiomyopathies, and we think inflammation has a role to play there. And that's why the guidelines for who needs an ICD in this case is not exactly the same as every other patient with heart failure. So in addition to ICD guidelines for secondary prevention and for primary prevention with EF less than 35% despite GDMT, there's some special cases where you would consider an ICD implant for primary prevention in patients with sarcoidosis, patients who have syncope, patients who have an EF of between 35 and 50 but have a history of syncope, have extensive scar on MRI, or have an indication for a pacemaker such as AV block. These patients, per the guidelines, deserve an ICD instead of a pacemaker. In addition to all this, these patients might also end up developing end-stage heart failure and need advanced therapies. The degree of LV dysfunction is the most important predictor of survival in patients with cardiac sarcoidosis. The 10-year transplant-free survival now in today's age with contemporary medications, immunosuppression, and ICD is as good as 90%, but that it's only possible if we diagnose this disease early enough to treat it. In terms of advanced cardiac therapies, these patients can be eligible for both LVAD and transplant. For transplants, the outcomes are similar. Post-transplant outcomes have been reported to be similar to other non-ischemic cardiomyopathies. But for LVADs, there are some considerations that you need to think of. Is the RV involved? Do these patients need to be on immunosuppression for other organ involvement? And how will that impact their infectious risk with an LVAD? And do they continue to have arrhythmias, which might also be a problem after LVAD? So what happened with our patient? So going back to our patient, she presented initially with heart failure. We did an endomyocardial biopsy, which was suggestive of giant cell myocarditis. So we started treating her as such with tacrolimus, mycophenolate, and steroids. 3 months later, we repeated imaging. Her echocardiogram had normalized. Her EF had totally normalized. Her left bundle had gone away, and she had no more arrhythmias. And we repeated a PET scan where her inflammation in the heart had gone away completely, but she still had mediastinal lymph node uptake. At which point, it's a little unusual. You can see mediastinal lymph node uptake initially with heart failure because of congestion, but it's unusual to have it 3 months later when you don't have heart failure anymore. So we decided to biopsy the mediastinal lymph nodes, and that's what showed us sarcoidosis. So it's interesting because giant cell and sarcoidosis are both inflammatory conditions. They're considered to be diseases on a spectrum. We don't exactly understand how similar or different they are from each other, but clinically we know that they're very different because giant cell confers a very different prognosis compared to sarcoid. And so then what we did was, based on this knowledge, we decided to downgrade the immunosuppression to just mycophenolate and a steroid taper. But 6 months later, when we repeated a PET scan, the inflammation had come back. At which point we decided to switch up therapy, go to TNF-alpha inhibitors, and now this patient is about a year into being on TNF-alpha inhibitors. Her PET is quiescent, her EF is normal, she has no symptoms of heart failure, and she remains on current therapy. So this is just to highlight that there's a lot of nuances to inflammatory cardiomyopathy. These cases can be very complex, and you need a whole team. It takes a village to take care of these complex patients. You need expertise in imaging, expertise in pathology, expertise in EP, rheumatology, ophthalmology, pulmonary. And here, our team at Montefiore comes together very well to take care of these complex patients. That's all I have, and I'm happy to take any questions.
Any questions? Yeah, I just want to make a comment about the team here. This is an absolutely fascinating disease that, as Dr. Rochlani told you earlier, is most common in Scandinavians and African Americans. There's not a single paper on sarcoidosis in African Americans. So Yogita has collected already about 50 patients or so with cardiac sarcoidosis and is studying the disease in the only randomized clinical trials. And she's doing a project with friends in Copenhagen that see Scandinavians with giant cell and sarcoid. And we're doing a study comparing phenotypes of these two populations. Something I encourage you strongly, if you have a sarcoid patient, to send them to Yogita and for Leandro. I didn't realize that we can do PET MR at White Plains right now. This is a brand new, right?
Yeah, so this is brand new. So it's something that is not available in many places, and we're lucky enough to have it at the White Plains. So it's a unique opportunity.
Yes, we're super exciting. Really state of the art. And we need also to send your patients because we will define treatment pathway for sarcoid, specifically in African Americans. And so help us with that. Great. So Leandro will take over and we'll go on to the next. Let's see. Are you ready for the?
Yeah, I had a question really quick.
Great. Yeah.
So I know the PET scan was mentioned for therapy. I just wanted to know if there are any guidelines that were out that recommended 3 to 6 months get an echo or PET or both.
Yeah, there are no clear guidelines about the timeline. So some of the literature says 3 to 6 months. Every center does it differently. I'm a part of a group of sarcoid doctors, cardiac sarcoid doctors across the country. Every center does it differently. What we're trying to do now is do it at 3 months so that we can start to get patients off steroids because steroids have a lot of side effects. There's some literature from Stanford where they do it even sooner at 6 to 8 weeks. There's some centers that do it at 6 months. Our practice here has been to do it at about 3 months. And we also actually have moved towards using a lower dose of steroids and a second agent up front, just because of the issues you see with steroids, particularly in patients who have diabetes, obesity, osteopenia, things like that.
Thank you.
Okay, so we move now to the next talk. That it will be.
I'm sorry, he has a question as well.
Another question? Sure. I'll repeat the question. Is about the levels of tacrolimus that are for these patients and if they need prophylaxis for opportunistic infections.
So the short answer to that is we don't know. I think with giant cell myocarditis, we don't use tacrolimus typically for sarcoidosis. For giant cell myocarditis, there are no set targets. In our patient, we kind of use the transplant. Early on, her level was closer to 10, and then, a few months out, when the inflammation went away, we came down. Actually, in her case, 3 months later, we found out that she actually has sarcoid, so I stopped the tacrolimus. But I think a month in, I came down, and opportunistic infection prophylaxis also, it varies widely how people do it, but for us at least, we've been doing. If you're on 40 of prednisone, you end up getting PJP prophylaxis. and screening for quantiferon and hepatitis and all the other infections that we would typically screen any patients going on immunosuppression for.
Thank you very much. So now we move to the next talk that it will be on hypertrophic cardiomyopathy. And our speakers will be Dr. Sandhya Murthy and Dr. Aldo Scanone, their co-director of Hypertrophic Cardiomyopathy Program.
Thanks, guys. Just bear with us for 1 second here. All right. Okay, so that was so promising for a second.
Mhm.
All right, I think we're in business. Okay, let's jump right into the case in the interest of time. So I'm going to present a patient I saw a couple months ago now. She's a woman, 66 years old. She comes in for the evaluation of shortness of breath, and you can see that from her vital characteristics here. She has obesity, but otherwise just high blood pressure that's fairly well controlled on diltiazem. And she's coming in complaining of worsening shortness of breath and fatigue during her Orange Theory class. So if you guys don't know, Orange Theory is a pretty intensive boot camp type exercise. So already, I think the clinical suspicion was not so high if she's able to do the Orange Theory class, but because of her persistence that she notices that something is going on, she's not able to go on the treadmill long enough as prior with fatigue. We started with an EKG and then we moved on with the echo. So I'll talk about her baseline EKG. It's quite normal, believe it or not. There was really not much to talk about here. I want to just outline some typical EKGs of a HOCM patient, if that's what you're suspecting. You usually, obviously see LVH, which is not so apparent on this electrocardiogram. The other thing that's described often in the literature is you see these deep septal Q waves in the inferior and lateral leads, which also we don't see here. So now Dr. Scanone is going to take over with the echocardiogram of this particular patient.
Thank you, Sandhya. So, one of the things that, in terms of hypertrophic cardiomyopathy, sometimes it's very difficult to kind of really get to the diagnosis. And I think we were lucky that we have a kind of a great team in the echo lab that has the expertise to get to that. I think one thing that we can see in these images is that in the first on the far right of the screen, you can see the function is preserved. You can rarely see that there's a little bit of septal bulge there, and right there with the arrow, you can see that there's a little bit of motion of the anterior leaflet of the mitral valve getting into the LVOT. In the image to the next to this, you can see in color Doppler that is a very significant flow acceleration in color Doppler. I think that's very important because then on color Doppler not only you can see that there is obstruction, but also you can define where the obstruction is, right? Because then many of these patients can have intracavitary gradients, they can have LVOT gradients, we can have patients that doesn't have necessarily hypertrophic cardiomyopathy, but actually have subaortic membrane, or this is aortic stenosis. So I think just taking a look at the collateral is very important to try to identify what's the level of the obstruction. And some of the patients actually present with complex obstructions, and you can see that there's a multi-level obstruction that makes it a little more difficult. One thing that I want to mention here is that we have to be very careful when we measure in echocardiography, because it's very easy to overestimate the septal wall thickness, or in some cases just underestimate, but you're not cutting through the area that is thickened. And remember that hypertrophic cardiomyopathy usually present with focal thickening most of the time, involving one or two segments. So sometimes can be easily missed. And when you see features that suggest the presence of hypertrophic cardiomyopathy, but the echo is kind of necessarily not conclusive, then I think it's important just to go to the next step. One thing that I think is important is when you measure the LVOT, you have to be very careful, because you don't want to be measuring MR signal. Often these patients present with abnormalities in the mitral valve apparatus, and that could be just SAM, but it could be also elongated mitral valve leaflets. You can have actually abnormalities in the mitral apparatus itself, and they can have or often come with mitral regurgitation. So I think it's also important to address for that, because that could be another reason why the patient's having symptoms in addition to LVOT obstruction. And as I was mentioning, you don't want to measure the velocity and say that the patient has obstruction when in fact you're measuring mitral regurgitation, as you can see here in the panel. You can see that you start right away after the QRS, and it has the typical kind of rounded envelope that you can see with MR. And sometimes you need to go off axis or try to do different projections to try to determine if the patient has obstruction, because or what the degree of obstruction is, because that's going to be important for not only diagnosis if you don't see necessarily fluctuation on the color Doppler, but also to see response to therapies if that's the way to go. On the last image, you can see here that is a very significant late peaking dynamic LVOT obstruction with a gradient that was up to 100 millimeter of mercury, which could easily explain her symptoms, right? As I said before, all these findings are non-specific, right? So we cannot say based on this echo and say, oh, this patient has hypertrophic cardiomyopathy just on the basis of the echo itself. I think LVOT obstruction in SAM is a very non-specific finding. You can have it with other pathology. You can have it with amyloid. You can have it with patient had hypertensive heart disease with a hyperdynamic ventricles. So just because you see a little bit of a bulge in LVOT obstruction, not necessarily just equates to the diagnosis of hypertrophic cardiomyopathy. And this patient needs to be followed up. In this case, usually the next step is kind of a cardiac MRI along with the clinical assessment, and that's why the team approach is kind of very important. So in this patient, we ended up doing the cardiac MRI, as I just mentioned. And here it's very important because you can actually measure the maximum wall thickness at each particular segment. And in patients, you can have miss on echocardiogram, or you can overestimate an echocardiogram. You can make a very precise morphologic diagnosis in these particular patients. You can see here on the left panel on the SSFP scene imaging, we can kind of redemonstrate, that there's definitely a systolic anterior motion of the mitral valve with significant, flow acceleration at the LVOT level. We're going to talk a little bit more about this, but I think for a long time, the emphasis of obstruction has been on the SAM and LVOT, and that's it. I think there are many factors that you have to take into account to understand what's the actual mechanism behind the obstruction, either intracavitary or LVOT. We're going to touch upon a little bit on that, and MRI can help you with that. Just going to make a brief mention here. So, we don't only see that the wall thickness is over 15 millimeters, which would be the threshold for morphologic criteria to suggest hypertrophic cardiomyopathy. But it's very nice when you see the correlation between wall thickness and presence of patchy LGE at that thickened segment, which really increases the likelihood and the certainty that this is hypertrophic cardiomyopathy. But again, all this needs to be evaluated in the clinical context.
Okay, so thanks to advanced imaging techniques and more awareness, we have some idea based on multi-international registry data about the incidence and the prevalence of this disease. So the red is countries that it has been identified in. The light countries are those with underdeveloped healthcare systems that probably this is just the tip of the iceberg here. So the prevalence is estimated to 1 in 200 to 500 cases, which is incredible if you think about it. It's probably more common than we think. Estimated about 20 million people are affected worldwide. So we don't know about probably 90% of the people that are carrying around this illness. What we do know from US data is that 750,000 people here have this disease. So what are our goals of initial presentation? You've established the hypertrophic cardiomyopathy phenotype. So now what we're really trying to do is define the trajectory of the disease. So half patients, roughly 46%, you're going to live with this. We see it on the echocardiogram. It shouldn't bother you. It shouldn't give you any symptoms. An additional 43% will have progressive heart failure. Now, who does this happen in? Mostly obstructive phenotypes. Okay, so those that with that LVOT obstruction, as Aldo showed you prior, those are the people that will have, that may have, half will have progressive heart failure. Atrial fibrillation, quite common in both phenotypes, so 17. So obstructive, non-obstructive, 17% will have atrial fibrillation. This is really the thing that scares us all, the 6% of sudden death events. So that's who you're trying to predict, who will this impact. These are major markers of risk. So these are the people that you want to really kind of screen for. Family history of sudden cardiac death, unexplained recent syncope, a lot of NSVT on Holter. LV apical aneurysms predispose you to sudden cardiac death. Massive LVH, over 30 millimeters of mercury. I'm sorry, 30 millimeters. Shouldn't be mercury there. Extensive late gadolinium advancement, this is where the role of the MRI is quite valuable in prognostication. And finally, end-stage heart failure under LVEF of under 50%. You should think about sudden cardiac death risk in these patients. Lower risk is age over 60. So if you've lived 60 years with this disease, the likelihood of sudden cardiac death declines. So that is actually the one instance in medicine where being older actually helps. Yeah, we're all almost there. So with the use of ICDs over the last 20 years, there's been a 10-fold decrease in disease-related mortality, and that has a lot to do with our abilities to predict who is going to end up in this 6% category. Okay. So busy slide, but I just want to take you through the highlights here. So the suspicion of HCM, and it's funny that we kind of glossed over the physical exam, but funny, but not funny. In a way, these are very obvious physical exams. You put your stethoscope on their chest, you will hear the obstruction. It is a very harsh systolic murmur, and that's the obstructive phenotype. That should get you to start thinking. And it is a classic kind of medical student exam. So that's the one thing that you will certainly hear in an obstructive phenotype, that harsh murmur. The history is really geared at looking at these major risk factors, personal symptoms of heart failure, family history, et cetera. And then the testing is a three-pronged approach with the EKG, looking for that LVH or the septal cues, the echocardiogram, of course, and the cardiac MRI put together. And concomitantly, you may want to think about genetic testing. Why? The importance here is really to look for phenocopies. And just recently, over the last year, I had a lady that was characterized as HCM, young lady, and genetic testing turns out that she had LAMP2 mutation, which is associated with Danon disease, completely different natural history and completely different management. So the importance here is to identify phenocopies like Danon disease, like Fabry's disease, different things that can kind of mimic the hypertrophic profile. Now, 30% of patients will have a mutation associated with hypertrophic cardiomyopathy. There's been about 2 major mutations, the MYL mutation and MYBC mutation, and those only 30% of the patients will have this. Most will have a negative genetic screen, but unfortunately, we're not at the point where we can predict, the genetic mutation does not predict sudden death events, and there's really no prognostic role of genetic mutation. So this is really in the infant stages, I think, of discovering these newer mutations and way to use this information as a way of prognosticating, but we're not there yet. But again, there is a lot of value in doing this just to make sure that it is not one of these mimickers, these great mimickers of hypertrophic cardiomyopathy. So once you identify this HCM phenotype, the real big question is obstruction or no obstruction, and that really will determine your course of care. So if there is a obstruction at rest, you're done. You have a resting obstruction, and you can kind of classically described phenotype. Half of you will do well, half of you will have heart failure, and kind of give some information to the family and the patient. If there is no obstruction at rest, don't stop there. And Aldo will talk about this, but there is a great deal of patients who have no obstruction at rest, but really the issues come with exercise. So that's kind of now I want to just point out something that's not in here as part of the diagnostic pathway, and that's left heart cath with hemodynamic studies, right? So left heart catheterization, not for the coronaries, but mostly to look at the intracavitary gradients with invasive hemodynamics. This is blatantly missing from the diagnostic pathways. I have to say there's still a role in ambiguous imaging studies, and there may be a role of actually characterizing where exactly the obstruction lies, whether it's subvalvular, whether it's intracavitary. So there is a role. I don't want to say there's really not much of a role of cath, but this was kind of the original description of Brock and Broke phenomenon and things like that with the cath lab, which is no longer in the diagnostic pathway, thanks to our excellent non-invasive imaging techniques.
Yeah, I think the understanding of hypertrophic cardiomyopathy with or without obstruction has really evolved over the years, and we feel that we can get to the diagnosis and really characterize the disease with minimal use of invasive techniques. So I think echocardiography is just the center, I would say, of in terms of imaging of cardiology. I think it's important that when you need to have similar that we talk with the amyloidosis, you need to have a high index of suspicion if you're seeing red flags or features that could suggest the presence of hypertrophic cardiomyopathy, either clinically, ECG, or on an echo. It's a very prevalent disease, and many of the people that we think have hypertensive heart disease or kind of small, septal notch may have hypertrophic cardiomyopathy, and it's relevant for many reasons. So first, we know how outcomes have really improved, and we cannot treat the patient and recertify the patient if we don't first diagnose the patient. So I think that's very important. And two, we can have cascade screening for the family and really have a kind of a massive impact. So every time you're seeing an echocardiogram, of a patient, I think it's important that you look for those signs. So the first thing is just, hypertrophic cardiomyopathy has to have hypertrophy, and kind of the morphologic criteria has been defined as you can see here with more than 1.5 centimeters or more than 1.3 in certain populations with either genotype positive, other typical features, and so forth. But I think what now we're seeing is that there's a lot of patients that still have hypertrophic cardiomyopathy but might not fit within that criteria. So that's why you need to be very, very suspicious about, if you see additional features, even if the hypertrophy is not over the established kind of guideline threshold. One important thing is that sometimes that's very focal. I have patients that the hypertrophy is not in the septum, is in the lateral wall, and then maybe the echo didn't capture that. So you have to be careful on that one. If you see any wall that is thickened, that is focal, then you have to be thinking into this diagnosis and maybe refer for further imaging. But the assessment doesn't stop in hypertrophy. Hypertrophy have been the center, but hypertrophic cardiomyopathy is way more than just hypertrophy. We understand now that there's energetics, ischemia, abnormalities in contractility that we're going to just see in a little bit. So I think it's important that you look for other features of the disease. So strain imaging can help, differentiate from other phenocopies. There have been many reports, and we have seen cases in which they present with, a cardiac amyloidosis and have like LVOT obstruction with SAM. And just because you see that, you're not going to say hypertrophic cardiomyopathy. That could be a phenocopy, and then strain imaging can potentially exclude some of the phenocopies, more or less in the first stage of imaging. I think it's important that you look for diastolic dysfunction, because then if a patient presents with shortness of breath and there's no obstruction, there are many other things why the patient can be symptomatic, and one of them is significant diastolic dysfunction, and that's important to identify and treat. When we talk about the obstruction, and we're going to talk a little bit more about the inducible, I think it's important you do your best effort to try to characterize the obstruction. Many of these patients present with intracavitary or complex multi-level, as I mentioned before. Maybe the papillary muscle is playing a role. Maybe the valvular abnormalities, to very elongated anterior leaflet, abnormalities in the orientation on the papillary, there's apical displays. those are important, particularly if you're going to try or you're considering surgery for someone who has LVOT obstruction with symptoms. You have to tell your team, I think this is the issues that I have, and we're going to talk more about that. And then finally, you have to, of course, evaluate for mitral regurgitation, because then, as I said before, SAM with an anterior pulling of the leaflet into LVOT might affect the coaptation and give, all different degrees of mitral regurgitation, often severe. But also you can have abnormalities in the mitral valve apparatus with mitral regurgitation despite the absence of systolic anterior motion. So I think echo gives you a good sense and a good screening technique to really go to the next level. So talking a little bit about obstruction, we mentioned that before. I think up to 70% of patients have obstruction. Although only around 30% have obstruction at rest. So that's why it's very important that you provoke your patient, especially the patient having symptoms. Remember, this is a dynamic process. When increased contractility, you tend to get the dynamic obstruction of the LVOT. So it's important that your patient, you put it and either, start with Valsalva, and then if you see anything there, just go to stress echocardiography to try to elicit LVOT obstruction and characterize the cardiomyopathy in terms of obstructive or non-obstructive. But also to assess functional capacity. That's going to be very important to guide the management of these patients long term. Recent data we just published like a couple of weeks ago, we know that people that has hypertrophic cardiomyopathy with early obstruction tend to have LV dysfunction later on. So it seems that leaving the patient with obstructive physiology might not be good in the long term. They might just end up with systolic dysfunction. So like with everything in cardiology, we try to detect the disease early, characterize it early, and just treat it early to prevent complications down the road. So MRI has is essential in the diagnostic characterization of the hypertrophic cardiomyopathy. First of all, it's more accurate than echo. I mean, you can measure correctly, and we know that the LV wall thickness might be a predictor of sudden death. So you really want to know if you know what's the size of your septum, or you have a kind of a lateral wall thickened that you might have perhaps missed in echocardiography. I think it has an enhanced capability of identifying mechanisms of obstruction. Okay, so we can see here in panel C, when we see this kind of aberrant papillary muscle that is inserting to almost the base of the anterior leaflet, and that area should be no papillary muscle. And we see often this with hypertrophic cardiomyopathy, and that can be the source of obstruction. So all obstruction in a hypertrophic cardiomyopathy is not necessarily SAM. Unfortunately, often we have complex obstruction with abnormal papillary muscle, abnormalities in the mitral valve, which is too elongated, with septal thickening and so forth. So you need to understand that, particularly if you're considering surgery in case your medical management didn't work, because you want to tell your surgical team what could be the factors that we might have to fix. If you have an eccentric mitral regurgitation, you think might be significant, and then MR can provide you with a little better quantification, by volumetric assessment. Particularly in apical hypertrophic cardiomyopathy, you can, assess for presence of LV aneurysm, and of course look for LGE and T1, which might be pronoxic. MRI also helps differentiate from phenocopys. I mean, Fabry's disease will have a completely different, parametric imaging with low kind of T1. Amyloid will definitely be different. So you can use not only to kind of identify, characterize your phenotype in terms of, hypertrophic cardiomyopathy, but to exclude things can look alike. Fabry's, Danon's, amyloid, and so forth. And that's kind of very important. So talking a little more about the obstruction, I think you can see here a variety of scenarios in which you have obstruction, hypertrophic cardiomyopathy with obstruction without the H. So you might have no hypertrophy and still have the abnormalities or minimal hypertrophy and still have the abnormalities in the papillary muscle and mitral valve leaflets that can lead to LVOT obstruction. And if you go in and you shave the septum, if you need surgery, you might not be fixing the issue. So you have to consider these other variants that are very important, especially in surgical disease. So here's like a pack slide, but this is kind of a nice summary slide. And I think imaging multimodal is kind of in the center of the management, diagnosis, prognosis, and follow-up of patients with hypertrophic cardiomyopathy, all the way from the diagnosis and exclusion of phenocopys we can see here. We can characterize the LVOT as I mentioned. I mean, we can detect other mechanisms, right? So not only, as I mentioned, LVOT obstruction, you can have actually ischemia. These patients are known to have microvascular dysfunction, and you can actually see, as you can see in the middle pane, image row on the far right, on the far left for you, you can see that there's significant apical ischemia in a patient with apical ACM. So, suggestive of, significant microvascular dysfunction. That could be the source of the symptoms. We can prognosticate, right? Wall thickness, amount of LGE, I think are important factors that are included in the new guidelines. Apical, aneurysm and so forth. There are novel things that are, coming out in terms of entropy and then how homogeneous that scar is and how it can favor reentry. So more to come. And I think the future is bright in terms of imaging in hypertrophic cardiomyopathy and in hypertrophic cardiomyopathy itself. And I think there's a great opportunity to follow up our patients, with treatment, particularly LVOT obstruction.
Okay, so let's wrap this case up quickly. We have options. We have lots of options. We have medical therapy. We have surgical myectomy and alcohol septal ablation. Those are the so-called septal reducing therapies. One is open heart surgery, and one is injecting ethanol, ETOH, into the septal perforators and creating scar and shaving, in a sense, shaving down the heart. So where do we lie with what we tell this patient? So let's talk about, before we talk about that, I want to just briefly discuss, especially a very appropriate to our patient who is doing relatively moderate exercise in the Orange Theory fitness classes. So what do the 2020 guidelines say? If you look at this pie graph on the I guess left, your right, is basically hypertrophic cardiomyopathy is the leading cause of sudden cardiac death in young athletes. There's several others, but this is, athletes being mostly basketball and football. These are the two big sports that this has been seen with. Now, the guidelines are a little bit ambiguous. They take on a more shared decision approach where you sit down with the patient, you're supposed to counsel them and say, hey, listen, your risk is this and that. And, we always have a risk, but understanding that the young athlete has a certain tie to a sport, and it's a more of a shared decision process. Anybody that's dealt with a teenager or young adult, I'm not sure that I would totally agree. And in fact, experts who have written extensively on this, including Dr. Marin, who's one of the forefront authors of hypertrophic cardiomyopathy, think that probably this is a little bit too liberal, and we should counsel these children, these young adults, in that it should be a disqualifying condition from heavy competitive sports. 36% young athletes are dying from this disease in cases of sudden cardiac death. I think it's a little bit, I understand the non-paternalistic approach, but for me, especially as a mother, young adults, children, that kind of thing, it scares me to give them the opportunity to fight me on this. But in any case, there's a lot of controversy when it comes to exercise, but what is known and what is fairly clear is that there is no evidence that non-competitive moderate exercise in Orange Theory fitness would qualify under moderate exercise. Competitive is really just defined as college or high school sports in football and basketball, that there's no elevated risk and does not promote disease progression. So we would say that patients should continue to do this if that's what they're used to doing. Medical therapy, I want to discuss the hottest drug on the streets here is mavacamten. So just to go back to a normal sarcomere, this is within the myocyte, right? This is a normal sarcomere. You have these actin filaments, you have the myosin, and you have these cross-bridging links between the actin and myosin. In a normal scenario, most of these actin and myosins cross-bridges are unlinked. They're not held tight to the actin filament. Whereas in hypertrophic cardiomyopathy, what we see is that there's an abundance of bound cross-bridging links compared to the normal phenotype. With mavacamten, the idea is to release some of these actin-myosin cross-bridges and essentially relax the heart. So why is this important? This is targeting the pathophysiology of the disease. Traditionally, all we've had is beta blockers, AV nodal blocking agents, and non-dihydropyridine calcium channel blockers, which basically will lower your heart rate essentially to allow for more diastolic filling time, but it does not address the underlying pathophysiology, which is that you would just have an excess amount of actin myosin cross bridges linked to the actin filament. So that's where the idea and rationale for mavacamten came in. I just want to review quickly this trial data. There's several different trials, the largest one being the Explorer HCM trial, where they basically took patients and randomized them to mavacamten versus placebo. And the primary endpoint was REACH, which is an increase in exercise capacity, increase in by means of peak VO2, your New York Heart Association functional class improvement. And importantly, what I want to point out is that this was the major adverse event, right? So sometimes it works too well, right? You release too many actin cross bridges, you're going to have a very relaxed heart, also heart failure. So the EF dropped precipitously in 3 patients in the initial pilot study, and 7 patients in the Explorer HCM, and 2 patients in the Valor HCM trial. So that's important to know. But other things is that this is a reversible agent, so that you stop the drug. It's a half-life of about 8 days, and this phenomenon will reverse, meaning your EF will improve, but it will be scary for the patients. The other important thing I want to point out here, this Valor HCM is very interesting. They took patients that were eligible for septal reduction therapy and said, why don't we delay that for a second, and we'll randomize you to either mavacamten or placebo. And at the end of the study period, you tell us if you still want the septal reduction therapy. So it was a very interesting trial designed that way. And it turns out that 77% of the patients on placebo wanted the surgery. Makes sense. Versus 18% of patients on mavacamten. So this is important for Dr. Lateeb and all the surgeons out there, that there is still a role for alcohol septal ablation surgery. Just throwing it out there, we're not sealing the business. So there is going to be a role, despite there's going to be a proportion where this is not as effective. And so I don't want to paint this as the answer to everything. There is still a role. So where does it fit in? For now, second line therapy after beta blockers and calcium channel blockers. And, non-surgical candidates, this is considered, we should really be considering this medicine. Prohibitive risk for surgery, certainly mavacamten, okay? Where this is being explored right now is a potential role in non-obstructive hypertrophic cardiomyopathy, and as well as a first-line therapy for obstructive hypertrophic cardiomyopathy. There's a second-generation molecule, aficamten, that's coming up with a much shorter half-life, and this is good for the reversal of the low EF. Some interesting ideas that the companies are looking at is the role in diastolic heart failure, which would be a game changer if this was actually a molecule that would relax diastology as well. So that's more to come. And I have to say, it's been very exciting being able to work with this medicine and seeing the almost immediate progress. Patients feel better in about 2 weeks. Echo improves in about a month. And I'll show you what happened to our patient here. This is 3 months post mavacamten.
Yeah, here we can see that. I mean, the images on the right, we can see the initial images that we obtained, and the first thing that come to to our eyes on the post mavacamten images is that that contraction of the ventricle is a little less brisk. Still normal, but it's a little less brisk. So that kind of really portray the underlying mechanism of mavacamten of really decreasing the number or restoring the number of myosin actin cross bridges. And we can see here is that although there's still like a mild degree of systolic anterior motion, I think there is an improvement in the flow across LVOT. We can see that as compared to your initial images, which is a very turbulent flow, now we see a very laminar flow with acceleration across the septum, which is normal. You see in all your normal patients, which is very reassuring. And you can see that despite resting and provocation, all we can see here is the typical signal across the aortic valve with no obstruction in this patient, this is what we're seeing. This is great, and we're helping the patients that before we couldn't necessarily help with medications.
That's all we got. Thank you very much.
Thank you very much. I think we do some quick questions because we're a little bit over time, but I'll start with one quick question. So should every patient with that we think on echo could have hypertrophic cardiomyopathy get MRI and genetic testing, or do you see any scenarios where they shouldn't?
Yeah, I mean, first, the diagnosis of hypertrophic is a clinical interrogative diagnosis, but I do think that in every patient you see an echocardiogram, you have features of hypertrophic cardiomyopathy. I think they deserve a cardiac MRI. First, because we really can, help with the diagnosis, but also we can exclude kind of phenocopies. So totally, every patient I see in the echo lab that I actually see features of it, and then match with the clinical picture, I refer for cardiac imaging.
Thank you. Any questions from the audience? One question here.
Just one question, because we still don't have any experience with mavacamten outside clinical trials. I would like to ask patients that are going to heart transplant. I heard some reports of dysfunction of the heart after heart transplants. Do you have any experience, or what do you do in these patients?
In mavacamten post or transplanting hypertrophic cardiomyopathy patients
On mavacamten.
on mavacamten.
On mavacamten.
Patients on mavacamten transplant them. We haven't done that.
We haven't done that here yet, but I anticipate, again, thinking about the half-life, 8 days, right? So there's a planning period that you would have to probably be off the drug for several weeks before. And I think that's the safe, just knowing how long it hangs around. But I can imagine on a normal heart, it would not be a good thing. Yeah.
So probably we have to stop the drug.
Stop the drug safely.
If the patient is advanced enough and will come up for a heart.
Yeah, roughly a month and a half.
Okay. So this was a totally fascinating to me. I learned a lot. I've only used mavacamten once, and the patient's ejection fraction dropped. So I immediately sent to Dr. Murphy, and she took care of it. But again, if you have a patient with HOCM, I think Sandhya has now experience in 15 or 20 patients, which is probably up there in terms of having such a large experience, sent her to us. And I just, listening to the 3 presentations, just decided we're going to do a 2-hour special symposium on these 3 topics with all the questions. But now we have to break, so we stay on time for the YouTube channel. We just do a 10-minute break and then restart right in here.
Perfect.
Thank you, everyone.
This was great. Yeah.
It was great.
Yeah, it was great. Thank you.
So interesting.
An hour and a half.
Yes.
Yeah,
You know.
yeah.
with the first, and we're gonna talk about beyond guiding medical therapy failure. The first talk by Dr. Costello will be on iron deficiency in heart failure. My pleasure.
Thank you very much. It's a pleasure for me to be here. Dr. Yordi has been my mentor since we met in 2009 at Columbia University. So I must thank him a lot I mean, he's meant a lot for me during my career. And also in the development of advanced heart failure and mechanical circulatory support in Spain, especially being able to send all the fellows we send yearly, which I'm sure you've met. So thank you so much for being here. So I'm going to talk about iron deficiency in heart failure. So this is something we do quite a lot in Europe to give intravenous iron to people with heart failure. And here, you don't do it as much. So I think what we're doing is interesting. And why are we doing it? And is this correct? So the first question is, how do we define iron deficiency in patients with heart failure? So quite a few years ago, we came up with this definition of iron deficiency, which could be functional or true iron deficiency according to transferrin saturation and ferritin. So patients with decreased transferrin saturation and a normal ferritin, we consider these patients to have functional iron deficiency. Therefore, the iron is in the macrophage in the form of ferritin, but it's not available for erythropoiesis or for the muscles or for the heart. True iron deficiency are those patients that also have low transferrin saturations, but have reduced ferritin. But as you can see, the value here of 100 is not the normal lab value. This value is higher because it was considered that patients with heart failure have an inflammatory process, and therefore we should increase this threshold to 100, similar to what was being done in patients with chronic renal deficiency. And this was the basis for actually treating these patients, this definition. This is a study we performed in more than 2,000 patients with reduced ejection fraction and preserved ejection fraction. And we assessed the prevalence of anemia and iron deficiency according to these definitions. And we can see that iron deficiency, both functional and absolute, we can find it in almost 50% of all our patients. Therefore, it is quite prevalent. And is this important? Is it always associated with anemia? Not necessarily. Actually, some patients have anemia but don't have iron deficiency. So we'll discuss this a little bit more. What we do know is that in patients with reduced ejection fraction, this definition of iron deficiency is associated with poorer survival, even after adjustment with other variables that could influence survival. And this was the basis of treating these patients with intravenous iron, because why not oral iron? We'll see later. There was a study that was negative, but in these patients with an inflammatory process, it was thought that oral iron wouldn't be absorbed appropriately. So therefore, this was the reason to give them intravenous iron, similar to what was being done in patients with chronic renal disease. So in this first randomized trial, when we participated, we found that patients treated with ferric carboxymaltose, the correction was done according to the Ganzoni formula. We found that these patients improved their functional capacity, they improved their 6-minute walk test, and they improved their functional class. And this was seen at 6 months. Also, this paper, for example, is interesting on how iron deficiency can, on how replenishing these iron stores can help our patients. For example, this study by Martens, a Belgian group, showed that patients after CRT that hadn't recovered their left ventricular ejection fraction, those that were iron deficiency, they were given intravenous iron, and we can see that there is a significant change in left ventricular ejection fraction, but also if we pace these patients, we can see an increase in cardiac contractility index, which we don't see in those patients that are not treated with intravenous iron. So there is some sort of cardiac remodeling that is favored by giving intravenous iron to these patients. And this actually seems to increase the cardiac contractility index. So it seems we're doing some good to these patients. So this is a meta-analysis that was published this year, which showed all the randomized clinical trials performed in patients with heart failure, with reduced ejection fraction below 50%, and it included more than 3,000 patients, and they all had heart failure and iron deficiency according to the prior definition we said of low T-sats below 20% and or ferritin below 100. And what they found was that we reduce cardiovascular hospitalizations, but we don't reduce cardiovascular mortality. So this is what led to the recommendations from the European and the American guidelines of a 2A class A or class B recommendation to give to these patients. They also recommend that we evaluate iron deficiency and anemia regularly in patients with heart failure. So what is the story behind giving intravenous iron to these patients? Well, how is iron managed normally in patients with and without heart failure? Normally, we absorb iron in the duodenum, but this is limited to 1 to 2 milligrams per day. And one important thing to know is that the only way to lose iron is to lose it through also the gastrointestinal system because the cells tend to fall off, or if you bleed, obviously you're going to lose iron too that way. And then this iron, which is absorbed in the duodenum, is bound to transferrin, most of it, because otherwise it's toxic in the blood. And then this is taken to the places where iron helps create hemoglobin, myoglobin, but it is also stored in the macrophages. And one important factor is hepcidin. Hepcidin regulates iron in the body. Therefore, in patients with iron deficiency, there is an increase in hepcidin. Sorry, there is a decrease in hepcidin that will allow the absorption of iron and will allow the release of iron from ferritin in the macrophages so that we have more iron in the blood, and therefore this can be used by tissues such as the heart, but also to increase hemoglobin and myoglobin, and also be used in the mitochondria for energy generation. This is a complicated slide, but I'm not going to go into the details, but what the theory, the classic theory of iron deficiency is that we have an inflammatory state, and this inflammatory state stimulates the production of hepcidin. And this creates this functional iron deficiency where we don't absorb iron, and this iron is taken to the macrophages and increases, is stored as ferritin, and we can't release this iron from the macrophages. So we have iron in the body, but we can't use it for the heart to increase hemoglobin, for myoglobin, and all these, and also to generate energy from the mitochondria. In this study by our group, we studied more than 2,000 patients with heart failure, both reduced ejection fraction, preserved ejection fraction, and we looked at the predictors of iron deficiency in heart failure patients. And what we found is that female sex is associated, they bleed more, and more advanced functional class, BMI, and higher NT-proBNP and lower hemoglobin are associated with iron deficiency. And when we looked at predictors of mortality in these patients, after adjusting for all the comorbidities and also for medical treatments, what we found is that iron deficiency per se was not associated with increased mortality in this big cohort of 2,000 patients. However, we found the other usual suspects, NT-proBNP, low sodium, low hemoglobin, diabetes, et cetera, et cetera. So basically what we found is that in our patients with ejection fraction below 40, above 40, we couldn't find an association with mortality with this definition of iron deficiency. So it actually cost us quite a lot to publish this data because it kind of was going against what the theory said and previous papers, but this is what it is. But we were actually treating a lot of these patients with intravenous iron. So up to 21% of all the patients that we studied were being treated with intravenous iron. And what we looked at is what patients were we treating. We were actually treating those that had iron deficiency, and we're actually treating more of the patients that had iron deficiency and anemia. So kind of makes sense. But we also looked at what patients, the profile of these patients, and they were more advanced, higher NT-proBNP, so worse prognosis patients, because it's in these patients that you think you can actually add something by giving intravenous iron. And we also looked at whether this was a safe therapy, so survival according to intravenous iron after adjusting for various covariates. So we did different models, and here we could see that in all the cases, even after adjustments, we found that our patients actually did better with intravenous iron than without intravenous iron. Obviously, this was not a randomized study. This is just observational, but it kind of reinforces the safety of this therapy. So basically, we see that there are some flaws in this theory about patients with heart failure, high ferritin, this functional iron deficiency. So this paper is very interesting because they actually tried to look a little bit further into this definition of iron deficiency. So they looked at hepcidin, which regulates all the iron metabolism, and soluble transferrin receptor, which actually increases as a response. If the cell needs iron, they're going to increase the production of this transferrin receptor to get more iron into the cells. So this study proved that in patients with heart failure and reduced ejection fraction, a true definition of iron deficiency defined as low hepcidin and high soluble transferrin receptor actually marked prognosis much better than the traditional definition of iron deficiency. And that is probably why our study failed to prove that iron deficiency didn't mark prognosis in these patients. And also, if we look at cardiac iron within the heart, we also found that the association between patients that had lower quartils of iron in the heart did not associate with any parameters, ferritin, transferrin saturation, iron in the blood. So this is a problem for defining what patients are truly iron deficiency. But one important thing is that if you look here at the bottom of the table, NT-proBNP is clearly associated with reduced iron content in the heart. So probably congestion plays a significant role in this iron deficiency in these patients. And this is another very interesting paper which looked at fibroblast growth factor 23. So this is an osteocyte-derived hormone that inhibits phosphate reabsorption in the kidney and regulates vitamin D. It is actually increased in patients with heart failure and congestion and activation of the renal renin-angiotensin system. And what they found here is that normally there is this association with lower transferrin saturation and lower ferritin with worse prognosis. But when you adjusted this according to the FGF23, the association completely disappeared. So this is probably something that is interacting with iron deficiency that we don't know exactly, if it's the chicken or the egg, but we need to look more into the mechanism of this iron deficiency in order to understand why it's happening, and if correcting this iron deficiency will actually help our patients. And another thing we also know is that ferric carboxymaltose administration produces hypophosphatemia. And this is more so in those patients that don't have kidney dysfunction. In the upper panel, you can see how after administration of ferric carboxymaltose, you can see that we increase TSAT, we increase ferritin, but you can see how phosphate decreases dramatically. And you can also see that FGF23, the one we talked about before, actually increases significantly. And this is not seen as much in patients with chronic renal dysfunction. So this interaction between the kidney, anemia, iron deficiency is very interesting. So is it only the iron deficiency, or is it also kidney dysfunction and also the anemia that all interact together? And here in this study, we showed that patients with more than 3 comorbidities, anemia, kidney dysfunction, iron deficiency, are the ones that do worse. So this is important to consider. Remember what I told you, that patients treated with oral iron don't seem to absorb as much. So they actually performed a randomized clinical trial here in the US in patients with heart failure. And what they found is that given oral iron, the increases in TSAT and the increases in ferritin were kind of very modest. So at least at 16 weeks. So maybe you need to give it for a longer period, or maybe it's just simply not effective. And they didn't find an improvement in the peak VO2 in these patients after given oral iron. That is why we normally don't give oral iron to these patients. However, the absorption of ferrous sulfate is not impaired in patients with heart failure. Obviously, if you're very congested, then it might be, but patients that are not congested, oral iron is actually increased, the absorption is increased in patients both with HFpEF and HFrEF. And also there are new formulations such as sucrosomial iron that increase your iron much faster and are better absorbed, that could be used in these patients. And this is something we could investigate in future clinical trials. So here, Dr. Patel showed us that patients with advanced heart failure have angiodysplasias that are correlated with higher NT-proBNP values, higher functional class, and actually they also have higher angiopoietin 2. So is it that these patients are actually bleeding, and that is why they are iron deficiency? We don't know. That could be an explanation to this theory, but there are probably more things involved. You can also see that these patients that bled, that had more angiodysplasias, also have had worse renal function. And here, Dr. Diaz, who's here, this is part of his thesis. He examined the differential gene expression in patients with iron deficiency and heart failure, and found that the expression of some genes was altered in patients, was actually up-titrated in some patients with iron deficiency. And here we can see that mitochondrial ferritin and sirtuin are actually associated with all-cause death in patients with iron deficiency. So there are certainly a lot more things we need to understand about iron deficiency before we can actually say that, we should treat this, because we don't know whether it's the real reason behind this worse outcome, or it's just a mediator, or it's just something we are observing. Very interesting. This paper was published last year. So patients treated with SGLT2 inhibitors, if we divide them according to iron deficiency and no iron deficiency, you can see that although there's no significant interaction, but the effect of treating these patients, if they were iron deficiency, was actually much better than in those patients that were not iron deficiency. And if we look at the ferritin, patients that benefited the most of being treated with SGLT2 inhibitors are those with lower ferritin, so true iron deficiency. So this is something very interesting. However, does this influence the increase in hemoglobin that we see in these patients? Well, actually, it doesn't. You can see that those with iron deficiency have a slightly lower increase in hemoglobin, but they still have this increase of hemoglobin. So iron deficiency doesn't impair this increase in hemoglobin. So how do we explain this? So this is a theory by Milton Packer, which shows us that in heart failure, inflammatory mediators and sirtuin-1, remember, Dr. Diaz also pointed that out in his study, seem to sirtuin increases, inflammatory mediators decrease with SGLT2 inhibitors, and this leads to the destruction of ferritin, liberating this iron and having this iron available for use to create hemoglobin, for example, increase anemia, and this might be one of the benefits, and is one of the benefits of SGLT2 inhibitors. So to conclude, in patients with heart failure, iron deficiency is seen in 55% of patients, and iron deficiency and anemia in 29%. We probably need better definitions than this old definition that was derived from chronic renal disease, and truly understand the pathophysiology behind iron deficiency before we can start treating massively these patients. We know that intravenous iron improves exercise capacity, quality of life, and reduces heart failure hospitalizations. Its use is safe. So should we use it? We use it a lot because it's safe and patients actually feel much better after it. So why not? So I would like to know what's your opinion about it. I know you don't use it much, but I'm open for questions.
That's basically a switch off. We have actually after speaking with you, Joe, and just I didn't properly introduce you. Joe and I worked together 10 years ago, and he's been back at Barcelona and has since become the director of the largest transplant program in Spain. I think this is Spain, the now recognized #1 LVAD specialist for sure, also probably transplant, and outgoing president of the Spanish heart failure section of the Spanish Society of Cardiology. To answer your questions, you guys should switch now. If you can come over here to answer your questions. We actually have been enlightened by you, and we have now a process by which we can give IV iron infusions through the hematology department here. So there's actually an e-consult that was established by hematology that you can use if you want patients who have iron infusions.
I know where that is.
Any other questions from the audience?
One question for me, specialist, of course. Do you have any predictor of, what are the best predictor for, iron deficiency to happen? We saw the angio. Yes. What else? Is there a way you can predict which are the patients that have a higher of?
No. Carlos, but it's not here.
No, it's off. It's red.
Did you change something?
No. So we did find that those patients with more advanced heart failure are clearly those that have more iron deficiency. So the more advanced your heart failure, the more congestion you have, the worse kidney you have, those are the patients that are going to have iron deficiency. So, and they're actually the ones that are more symptomatic. Therefore, given something that helps them improve their quality of life, I think is something that's why we give it. It is safe. We still, I mean, there is it a class 1 indication? I mean, we don't have the cardiovascular mortality to back it up. So I think keeping it in two-way is probably good. But I mean, LVADs are two-way.
Yeah.
And we're using them regularly. So why not?
So it's 2A, and actually just a week or two ago, injectable iron we're behind Europe as usual. Just a week ago, too, was the injectable iron was approved by the FDA for use in the United States. So it's fully reimbursed. So definitely a therapy that we will use a lot more. And there's actually a booth outside that has all relevant literature if you wanna stop by there. So now we're going to go. Joe used to be my fellow when he was younger, and now Carlos, who is Joe's fellow, and spending a year with us, will talk to us about the cardiorenal syndrome. A brief overview.
Yeah, thank you, Dr. Jordi and the organization for having me here to speak in such a terrific symposium. I'm going to talk of one of my favorite topics, which is the cardiorenal syndrome, and I will do it brief as asked. So I will divide the presentation in 3 main points. So what, why, and how do we approach to cardiorenal syndrome? So first of all, what do we mean with cardiorenal syndrome? And the first thing to say is that this is a very old story that started back in 1840. Dr. Bright, who used to treat patients with albuminuria, which we would call now also a nephrologist, found that in the autopsies of these patients, he usually found left ventricular hypertrophy. So that's the first evidence of this crosslink between heart failure and the kidneys. But still we are here. So we have a patient with impaired ejection fraction, heart failure, and impaired kidney function. And these are the kidney team telling the heart failure consultant the blame is the heart, and the heart failure team blaming the kidneys because the patient is not going well. So what can we do to that? So far, we have a state-of-the-art definition for cardiorenal syndrome, which is kind of something like a maladaptive crosstalk between the heart and the kidneys. And it is divided into different types, 1, 2, 3, 4, 5. The first 2 stand from the heart being to blame. 3 and 4 is the kidney to blame. And the 5th is something like a milieu of diseases, systemic diseases that affect both heart and kidneys. And I have to say that I don't believe in these definitions and I don't believe in this classification, because I think most of it is about congestion and the heart failure syndrome itself. And when we talk about cardiorenal syndrome, we're mostly talking about the very heart failure syndrome. And this is why I said that. This is an old study, 28, and another one from 2016. On the left side of the slide, we can see that it is the central venous pressure, the one that correlates better with the presence of worsening renal failure in the patients admitted with advanced heart failure, and neither the blood pressure, the cardiac index, or the wedge pressure do correlate with the presence of worsening renal failure. And what's more interesting is that actually cardiac index was better when the kidney was worse. Probably it's a vasodilator state, I don't know, but that's what they pointed out in 28, and that was also replicated in 2016. There's a prospective study of patients undergoing catheterization for heart failure, and well, that's actually a post-hoc analysis of the ESCAPE trial, and they saw that none of the usual biomarkers that we use to analyze the renal function was associated with cardiac index, and again, it was the central venous pressure, the one that was correlating with it. So why do we talk about cardiorenal and how does it happen? So this is the relevance of chronic kidney disease around the cardiac heart failure spectrum. around 30 to 50% of patients with heart failure do have any sort of chronic cardiac disease and chronic kidney disease, and that correlates with prognosis, meaning that the patients with worse renal function do also have worse prognosis. And in the middle of this interplay, it's the fact that these patients also have a higher proportion of cardiovascular disease. And this is very important because, again, this is the initiation of both syndromes. The first I wanted to talk about is about the concept, the kidney tamponade hypothesis. We talked about congestion, but this is not just about the renal venal flow in terms of renin, angiotensin, aldosterone activation or whatever. It's just the fact that there is a lot of pressure to the kidneys. So this stands both for the glomerulus. If we have a high CVP and we have the same blood pressure and cardiac output and effective flow to the kidneys, the gradient between what's getting in and what's getting out diminishes. So the filtration slows. Also, there is venous congestion at the tubulus. So we provoke hypoxia to the kidneys. And again, in a bigger picture, we can see that in the abdomen, we are actually not helping the blood flow to go across because we have a lot of pressure. And we also impair the cortical function, which are the most vulnerable part of the kidneys when we have ascites for patients with very severe right heart failure. And what is really happening from a pathophysiological point of view? What happens in heart failure is that the kidneys receive less blood flow. So there is less sodium getting to the macula densa. So the kidneys think we have not enough blood flow. What that happens then is that the afferents arteriole dilates, so there's more flow coming, and the efferents contracts, meaning that the pressure inside the kidneys increases. We damage the podocytes, and we increase the level of lost nephrons. Again, when we go to the table, the lymphatic flow is increased. So there is more reabsorption of sodium to the blood flow. And what happens at the macula densa is, again, we have low sodium, and then we further activate the renin-aldosterone axis. And then the clinical consequence, we have diuretic resistance. I won't get too much far into it. I will get more practice. There are a lot of determinants to that, but one of the main things is that in the end, we have a lot of reabsorption of sodium across the nephrons. And what is the other clinical consequence? Progression. The first thing that happens in heart failure is that we cannot measure appropriately how is the kidney function going to our patients. And there is a subclinical deterioration that it is very hard to detect during the normal outpatient clinic follow-up. And there is a lot of patterns in the changing of the creatinine and the calculated glomerular filtration ratio during admission and the acute phases that we cannot really detect which is the real kidney function of our patients. And on the contrary, when we have a lot of albuminuria, which is one of the most important factors to both the prognosis of heart failure, but also kidney disease, it's the progression of both diseases at the same time to a higher level than patients without proteinuria. So how do we approach to cardiorenal syndrome? So for acute decompensated heart failure patients, I want to just expose our experience in Barcelona. What we do is to do things very early. We early treat patients with diuretics. Probably these patients already have diuretics even when they are in the ambulance before arriving. And we early and comprehensively reevaluate both the urine output, but also the sodium. And also we do a thoughtful congestion assessment to all the patients during the follow-up. And that is based on this consensus statement from the European Society, which states that during the first hour of admission, you have to start diuretic treatment. Everyone has his own recipe. For us, it's 2.5 times the diuretic dose, or 40 milligrams for naive patients, and early reevaluate this treatment effect at 2 and 6 hours by measuring not only the urine output, but the natriuresis. And depending on the response to the treatment, so the effect of treatment by both the congestive status, but also the urine output and also the natriuresis, we decide whether we have to double the diuretic dose or we have to carry on with the same dosing. And there is more and more evidence growing on the importance of sodium at the urine to check what is going on with our acutely decompensated heart failure patients. And that not only stands for the weight loss of our patients, so the effective decongestion, but it also affects prognosis. On the right side of the slide, you can see a sub-study from the ADVOR study, which actually says that it is natriuresis, the one that guides the effect of treatment in prognosis. Either they even have acetylcholamide or just furosemide, the fact that they could reach higher levels of urine sodium just correlated with good prognosis. And also what we do in Spain is to do further evaluation of congestion. We just use the POCUS approach. That's one of the things that we can do. We can see the vena cava, but we know that this is a late state of congestion when we see the vena cava or the patient is clinically congested. We know that there are initial stages, and these initial stages can be detected by using a Doppler targeting the venous flow in the kidneys and in the portal veins. In the right side of the panel, you can see that the portal vein starts having bumping when you get congested, and it can even get reversed. In the lower side of the slide, you can see what happens at the renal venous flow. The renal venous flow is continuum when it's normal, but when you start getting congestion, it starts bumping. And in the end, you can even get monophasic. And you have a long time when there is stasis. That means that there is no flow going out of the kidneys. So that is what's happening actually in heart failure to the kidneys. And this also correlates with prognosis. This is a prospective study of patients undergoing catheterization. I know I hear and learning a lot about catheterization, but this is what these doctors did back in Japan. What they did is to do a Doppler and to add this Doppler of the kidneys to the prognostic risk stratification. And what they saw is that in the multivariate analysis, sodium, BNP, but then only the pattern at the kidneys correlated with prognosis. And it was the monophasic extreme congestive state, the one that correlated the most with prognosis. And that is even on the top of having a high right atrium pressure. So what do we do then? We do the patient's persisting congestion. We have to add new diuretics. We have to block all the nephron. We have a lot of drugs that we can use to them, but I just want to stop by two things. First, use the combination that you would like more, but then please do a good pre-discharge decongestion status evaluation. You have to see that the patient is going out without congestion. If not, he will come back. And for that, we have some trials that have come across us lately. This is the ADVOR trial. I know there's a lot of criticism around this trial, but what I could say about this is that what we saw is that we can effectively add another drug to our scheme of drugs for patients with acutely decompensated heart failure, and we can get an appropriate decongestion with another drug than furosemide. And what we can do is to get a good natriuresis that we know that correlates with prognosis. And this happened around the whole spectrum of heart failure. So this is why I believe in acetylcholamide. The ADVOR didn't have SGLT2 inhibitors. We still have to see what happens with that, if that is combined, that combination do help or happen anything, but I think this is a good thing. The only place that we don't use acetylcholamide is for patients with hemodynamic compromise or with acidosis, because it doesn't help at all, because it blocks the anhydrase, the carbonic anhydrase. And then it's the thiazide diuretics. We have a lot of data from retrospective studies saying that thiazides correlate with back prognosis, but this is the first trial that tried to use thiazides in patients that coming with acutely decompensated heart failure. This is a very old population, 83 years old, with a lot of comorbidities, a lot of HFpEF. And these patients do have a more accurate and better congestion by using thiazides. The only thing that you have to keep in mind is that you might have higher creatinine values. Whether this correlates or not with kidney function is to be seen in the long-term follow-up, and that you might have hypokalemia and hyponatremia. So these would be red lines to not cross when treating these patients. And then it's the renal replacement therapy. Omar will talk about this, but what I would say about that is this is winning a battle, but we are losing a war. What we do with our patients in the chronic setting as a palliative care is do peritoneal dialysis, and I think that might help for some of these patients, and we have very good experience with that. And what happens with GDMT in the chronic kidney disease? We don't have that much data. I like to call it like the dark side of the moon. We don't know where we are going through, but what we know is that we can reduce the slope of the deterioration of the glomerular filtration rate of these patients with both ARNIs and SGLT2. And that happens for two things. ARNIs not only have the IRBs as AC inhibitors effect, which consists in dilating the efferents arteriole. We have talked about that. So we reduce the hyperfiltration, but also have the natriuretic effect of the peptides and reduce sympathetic activation. And we know that there will be drops in the eGFR for these patients, but we also know that despite these drops, these patients behave better in terms of prognosis, both for heart failure admissions, but also for mortality. And then is the SGLT2. We talked about this before. And we know that for me, this is the cardiorenal drug. This is how it works. We tackle both. We tackle the heart. We tackle the kidneys. What we are doing is to deliver more sodium to the macula densa. So the macula densa says, hey, we are hyperfiltrating here. We are too much on the schedule. So what it does is to block this reaction. So we are acting not after renin is secreted, but before. And that is a change in the paradigm of treating this kind of patients. So what is cardiorenal syndrome? Cardiorenal syndrome is in the middle of heart failure syndrome. It is a continuum, and I don't think it can really be classified. And why I say that is because both heart failure and chronic kidney disease have similar risk factors, mostly cardiovascular ones. Dr. Murthy talked about the stages of heart failure. Stage B heart failure stands for patients with a structural but not clinical, and A are patients at risk with cardiovascular risk factors. It happens the same with chronic kidney disease, and there is a continuous feedback. We have always to identify the main components of the deterioration of both heart and kidneys, and for that we have clinical signs and symptoms, but we have to use better our biomarkers and, again, imaging. We have to avoid persistent congestion of these patients. There are a bunch of patients which are in the outpatient setting that have persistent congestion. We have to fight that if we want to fight for these patients, and we have to avoid hyperfiltration by using GDMT. And for that, I propose the stepwise approach and continuous surveillance in these patients in units like this that we are now having in Spain. So cardiorenal units, we have multidisciplinary teams that work together, kidney consultants, also heart failure nurses, all of us for the same patients with high risk of both heart failure and chronic kidney disease deterioration. So thank you very much, and open for questions.
The question from.
Sit here you can see Carlos.
And yeah, question.
Shivan? Yeah, we can hear you.
So, Alice,
Just want to make a quick comment on that, on the 8 hours in ER. I completely agree with that. And we actually have a major initiative that's happening in the ER here right now, where a specific diuretic pathway is going to be used and then transitioned into an observation unit. So hopefully that would be like what you have in Spain. That was outstanding. I really also like the ultrasound of the kidneys, which we don't do here, which is a major shortcoming of, I mean, Carlos is doing it for us now, but this is something that we will implement here routinely. So thank you for teaching us on this.
So staying on the cardiorenal syndrome, the next speaker, our own Professor Omar Saed, that will talk about the device-based therapy and the future. And we need a very concise presentation since we have over time.
Sure, no problem. Thanks, Luigi. I'm going to talk about, can we use devices to improve congestion in all the cardiorenal cases that we see? I don't have disclosures for this presentation. So as as Carlos just showed us, that congestion defined by CVP or an intrinsic renal disease are both two factors that are associated with worsening renal function. This is a term that's defined in this literature. When the creatinine goes up by 0.3, you're in this worsening renal function category. These are patients that are admitted with decompensated heart failure. And the figure on the right just shows prognosis. So in the red, those are the patients that remain congested and are discharged. They don't do well. So they have higher hazards of having poor outcomes. So we got to get rid of the congestion. The mainstay is diuretics, right? So we want to reduce this. Patients get Lasix 40, Lasix 80, 160. They're not diuresing. The creatinine goes up. Diuretics are stopped. The hospitalization is prolonged. Everybody's confused. Is it over diuresis, under diuresis? Call a heart failure consult. Ultimately, this leads to a prolonged hospitalization. And we do know that higher doses of diuretics activate the neurohormonal axis. So they have adverse events related to that. And they're associated with higher mortality. That could be the actual disease state, but it's another factor. Just before I get into the two devices quickly, we do ultrafiltration in the clinical setting, just use the dialysis machine, take the fluid out. It was actually a randomized control trial that was done. You randomize patients to diuretics or doing that method, and there was no difference in the amount of fluid you can remove. The creatinine was higher in the red there with ultrafiltration. So based on that, this is not a class 1 indication. We do it in cases that we just can't remove the fluid otherwise. Now, can we use a mechanical intervention to just lower the preload mechanically and then improve direct resistance? So this is the first device that there's an early phase study that was published. It's the Precardia system. So this device is put in through the SVC. It's a 13 French sheath. And then the distal part of it is in the PA. The device is actually inflated in the SVC. And there's the duty cycle of 5-minute occlusion and it relieves after for a 30-second period after that. And this cycles, and the patients that were enrolled in this trial had this device put in for 24 hours. I'm just going to go through the data of that study. This was the paper. So the key eligibility criteria are listed here. You guys can see them. These are essentially patients with decompensated heart failure, stage C and D, systolic heart failure. Patients had to have a right to pressure over 10, and elevated wedge pressure. One point is that the inadequacy of diuresis was determined by the investigator. So, I can call Lasix 80 kind of the end of it. Somebody else calls it 160. This is just a subjective thing. When do we draw the line and say, oh, it's just too much diuretic, now we got to enroll them in the study? This was a subjective criteria. The patients were volume up at enrollment. So the endpoints were, basically this was a small study, really designed to assess safety and feasibility. So no adverse events were looked at closely, neurologic events, and dyspnea scores were done. So moving forward, these were the patients that were enrolled. So 41 patients were enrolled and 30 then further proceeded that met all the criteria. One patient had the catheter put in through the left IJ, which didn't work well. So that patient didn't go through the whole study. So left 29 patients and for whom we'll see the data for now. These are the demographics. The patient is 65 years old. You can see their heart failure stage C and D, and their EF was about 28%, and these were dilated hearts. LV diameter was 6.3. So what happened? Before I get to the results, I do want to point out in the supplement of the study, so what was the threshold of inadequate diuretics? So the patients were not really on thiazide diuretics. We used metolazone and chlorothiazide. In this study, that wasn't being used. So that's something to think about. Some patients, though, did have up titration of their diuretics while they had the device in. So they broke it down by who did or did not have up titration. But either way, not many patients were on thiazide diuretics here. It was safe. So adverse events, major adverse events did not occur in the patients. So that's reassuring. And device was able to be placed as is supposed to be. And as far as the hemodynamic effects, you can imagine, it did work by occluding the SVC, the right atrial pressure and the wedge pressure came down. So did the PA pressure. The cardiac index was not affected despite lowering preload in this transient fashion. Neither was the cardiac index. But the filling pressures were reduced, you can see here. And interestingly, even after the treatment, 3 hours afterwards, some of these cardiac pressures remain reduced. Just a bit more detail about the right atrial pressure. That's in the square line, and then the wedge pressure. So at baseline, the right atrial pressure was 17, the wedge was 30. This is very high, right? The normal right atrial pressure is about 5 to 8. So these patients are volume overloaded. But once as the treatment was initiated, the pressures decreased and remained low after the treatment. Not every single patient had a reduction, as you can see by the other graph. The other studies, so neurologic safety was important because you're inflating a balloon in the SVC. So that was studied with these two metrics, and there were no neurologic adverse events that were observed in the study. And the dyspnea, as I mentioned, it improved. One thing to look at, if you just say, well, what if it was just because they increased the diuretics too? So the authors broke it down. So in the patients who did not have an increase in diuretics after the device was placed, this is the without an increased diuretic group, there was still an increase in urine output. It doubled with the device in this 24-hour period. So that's interesting. And at the end, this was safe and feasible to keep this device in place for 24 hours. It's a single-arm study, so we don't know how effective it really is. There's no control. It was open label, so the patient-reported outcomes are always questionable. Patient has a device and they usually just feel better unless it's causing an adverse event. We do need larger studies to understand the efficacy. But moving forward to the second device, I just wanted to mention, this is this Doria catheter that you may hear about to improve congestion in patients with decompensated heart failure. So this device is a similar concept, but now we're going to be putting it through the femoral vein into the IVC, and it's going to sit below the renal veins. Once it's placed, then the device is deployed, and it's a partial reduction in preload in that area. This is a video of the device being put in to the femoral vein IVC. You can see here, threaded over the wire. Once it gets at the appropriate level below the renal veins, it's deployed, and this is a partial obstruction. The idea is really to reduce renal vein congestion. And the data I'll get into that was published. So this was a small study, first in human, it was 9 patients. The key inclusion was patients admitted with acute heart failure with an elevated CVP. This was designed to really study safety up to 1 month and technical success. And they also measured urine output after the device was deployed. So these were the characteristics of the patients. Again, people with reduced EF, about 24%. And the device, at baseline, the urine output was 77 mLs per hour. The device deployment time was 8.5 hours. There were some adjustments after it was placed to optimize the effect. And we can see the data here. So number one, it was safe. So they were able to put it in all the patients and then remove it. There were no adverse events. One patient did have the swans were also in place while the device through the neck. And one patient had a hematoma at the swan site, but there were no device-related adverse events in these 9 patients. And so here are some of the findings. Urine output in the blue increased after device placement. Again, reducing renal vein pressure with similar diuretics. So diuretics were not escalated while the device was in place. And despite not escalating diuretics, the urine output increased. And as you can imagine, the CVP dropped. This again just shows per patient. So all patients had this effect of increased urine output. And how effective is it? So they also measured the gradient, and the gradient dropped by about a mean of 6 points. So fair effect. And this is blood pressure. So despite inflating something in partially inflating it in the IVC, the blood pressure stays stable in these patients. Overall, I think the study does show feasibility and safety of the catheter, and it can modify IVC pressure, but of course, larger studies are needed to understand efficacy. I had to go through that a little quick, but I think it drives home the point that the devices seem safe, and we'll see what larger studies tell us about efficacy. Thank you.
Thank you, Omar. That was terrific. Let's do a quick changeover. I have a conflict with the Dwyer device, so I just want to say that even it is trivial conflict, but it exists. I really office, and we're talking about the patient. And I'm just going to ask some basic questions that I have about AFib, because the connection AFib, ablation, and heart failure is, to me, still somewhat nebulous.
Thank you, Uli. Thank you for changing the plan a few days ago, but we are here. So it's not a debate, but kind of a debate. So we're going to focus not on ablation and devices in general, but on atrial fibrillation. So Uli, you want to start with whatever you want to know from me. We're going to kind of discuss already. So we need to keep you awake also. So.
Yes, Dr. DiBiase. I have a patient with HFrEF, ejection fraction 30%, New York Heart Association class 2, and long-standing atrial fibrillation. Should we ablate this patient?
So these are my disclosures. So here's a patient with 30% AEF and long-standing persistent atrial fibrillation. The first question is why this patient has a long-standing persistent atrial fibrillation? Why you guys didn't send me the patient before? That's the first answer. Because I don't treat long-standing persistent, I do paroxysmal atrial fibrillation. A concept I want you to have is that we EP are treated as surgeons, but we are cardiologists. And of course, we understand heart failure. And before we treat any patients, we understand, we go step by step, and we treat with medication all our patients, and we guided medical therapy. We heard this session today. So I want you to know that I understand cardiology, I'm a cardiologist, and I want my patient optimized on medication to undergo a procedure. I just don't stick catheter in the groin, just for fun. And ablation is not salvation. What I'm trying to say is that Dr. George probably tried to restore sinus rhythm with medication, shock, anything else, tried to say, I have the patient is rate control. When he couldn't do it anymore, he called EP. So ablation is no salvation. Please call us earlier. I picked this study, which is one of many trials we'll show later about atrial fibrillation, ablation, and heart failure, because this study based the ablation on the MRI results. And you can see that when the LGE is negative, you have the best reverse outcome of the ejection fraction when sinus rhythm is restored. It means that probably we have a sort of tachycardia-induced cardiomyopathy. Many patients actually, by going back to normal rhythm, they have a complete normal heart, including the MRI, can restore sinus rhythm and do very well. Although the overall patient did better in sinus than in heart failure. And from the trial, you can see that this is the first randomized clinical trial to compare EF in the restoration of sinus rhythm in patients with persistent, not long-standing persistent atrial fibrillation. The key findings are that the catheter ablation was associated with a significant improvement in EF. And this finding was accompanied by a reduction in atrial and ventricular chamber dimension, BNP level, New York Class Association. The absence of ventricular RGE on cardiac MRI imaging was associated with a greater improvement in LVEF and higher likelihood or normalization of the function. More importantly, these findings indicate that in this patient, AF may either significantly contribute or indeed be entirely responsible for the left ventricle systolic diameter, and that the benefits of sinus rhythm, as confirmed by ILR, were present in spite of adequate rate control, supporting the concept that AF-mediated cardiomyopathy may occur independently of ventricular rates. Furthermore, those patients without LG or CMR exhibit significantly greater improvement in systolic function with the restoration of sinus rhythm, suggestive of an underlying arrhythmia-mediated cardiomyopathy. And importantly, this study population has largely flagged pharmacologic rhythm control with amiodarone in 86% of the patient, with 90% of patients having an average of more than 2 cardioversion attempts. In this study, catheter ablation offered an effective rhythm control strategy for this patient with previously ineffective antiarrhythmic medication used in concert in 1/3 of the patients. So I think it's important that even if you have a good rate control, sinus rhythm matter. That's my answer to you, Uli.
Okay, I think I understood that. So I have a patient that I started on amiodarone, and he converted to sinus rhythm. Why not leave him on amiodarone?
Okay, if you want to talk about amiodarone, let me jump slide then, because you are now jumping on amiodarone. Okay, you want to do amiodarone? I have amiodarone for you. So I actually did a trial on amiodarone, and this is a trial with persistent atrial fibrillation in patients with ICD and CRTD that were randomized to catheter ablation versus amiodarone, all in heart failure patients. It's a Circulation paper 2016. You can see the success rate of catheter ablation, 70%, and amiodarone, 34%, after a mean of 1.3 procedure. What is important in this trial is that if you limit the ablation to PVI alone, the success rate is as bad as amiodarone, and you need to do a more extensive ablation. So you need to have a more specialized procedure and center to perform this ablation. And in the trial, and this after an average of 1.4 procedures, in the trial, the success rate of catheter ablation could vary from 29% to 61% with one procedure across centers. This was a randomized trial where we had high volume, low volume centers. So I give you the benefit of doubt that when the procedure is not performed in a high volume center, there is a difference. Also, it's important to note how important is sinus rhythm. In this slide of the paper, I actually put together patient with recurrent AFib and patient without recurrent AFib. And the no recurrent AFib were either in 1 of 5 patients where was achieved by either ablation or amiodarone together. These are the patients where you benefit in EF, 6-minute walking test, and Minnesota questionnaire. So the importance of sinus rhythm in this trial is very, very clear here.
Okay.
I think one thing I can say, maybe you can say later, but you really want to give amiodarone? I mean, you're worried about this, but we can talk about complication later.
Okay, I understand. I think sinus rhythm is good, amiodarone is bad. This so far we got now.
And actually, let me tell you
No,
one
no,
more thing.
Luigi, I have
Let me tell you
another
one more
patient
thing. From heart failure patients, you
that's
guys,
stuck on the amiodarone.
these are your own studies. These are patients with ICD versus placebo or amiodarone in patients with heart failure. Look at your nice amiodarone use. What's happening to these patients. I know it's for mortality data, but I mean, amiodarone for sure is not the way to go in these patients.
This
Sorry to
was
say that.
generation heart failure cardiologists before me.
Yeah,
So
before you.
please. But Luigi, amio is bad, but I have another patient who has atrial fibrillation, same patient, but who's on beta blocker, because I didn't want to give the amiodarone. Now she's rate controlled. She's also a NUR2. Why not just wait? Or why do it at all?
Okay. Let me go back. So people don't believe in ablation in heart failure, but we have 1, 2, 3, 4, 5, 8 randomized trial we put together into a meta-analysis with actually fellow here. And we look at the data. Meta-analysis have limitation, but we have 8 randomized trial into a meta-analysis, not just observational study, randomized trial. This is the outcome. Better all-cause mortality, better change in LVEF, and better arrhythmia, atrial arrhythmia recurrence. Both procedure, medication and ablation have possible side effects, but the impact of ablation is clear in all 8 randomized trials. So this is number 1. Also, if you look at the most famous one after the attack versus amiodarone is this trial here on New England, which showed that of improvement with a relative risk reduction of 38% from death or hospitalization, death from any cause, and hospitalization from worsening heart failure, clearly favoring ablation. And what I like about this trial is that when you look at very old heart failure trials and you look at advanced NIA class association, the importance of atrial fibrillation is not there. You're not gonna improve survival if atrial fibrillation comes in. But when you have class association 1 and 2, which are the one with the higher risk of mortality, actually, the presence of atrial fibrillation has a clear impact on mortality and heart failure. These are very old data that are still valid. If you look at the sub-analysis of this trial, you can see here the CASTLE-AF trial. You can see that the impact of the New York Class Association is given by the lower New York Class Association on all death from any cause, death and cardiovascular hospitalization when comparing medical therapy and ablation. And the same effect is on the improvement of ejection fraction. So the best patient for us are the ones that have an ejection fraction more than 20%, 20 to 35, and they have a class association of 1 and 2, which are the one where you usually say, let me treat them with medication, let me rate control, and when you cannot do it any longer, you send it to us. So I think it's important to know that the ablation, when the patient is at the beginning of atrial fibrillation or is healthier patient, is the best way to go. And that was the first answer for you. The second one is, you said, I have to jump, is timing, okay? So, timing really matters, and we don't want to wait. So we have now studied New England Journal of Medicine, early rhythm control therapy in patients with any type of atrial fibrillation. Even if you have heart failure or not, it doesn't matter to me. It does not matter to me. 21 relative risk reduction of composite of death, cardiovascular causes, stroke, or hospitalization when you do sinus rhythm. So for me, sinus rhythm matter. More importantly, if you look at the progression of atrial fibrillation progress. And when it's more persistent or long-standing persistent, the risk of death and stroke increase over time. We know this very well. So atrial fibrillation is a chronic and progressive disease. Persistent atrial fibrillation is associated with a worse clinical outcome. And catheter ablation is much better than medication preserved sinus rhythm. So why to wait? Where are the data? This is a nice meta-analysis here showing the progress of atrial fibrillation and the worst outcome of this patient when you have paroxysmal versus persistent atrial fibrillation, or when you don't have at all atrial fibrillation. And this is the ROCKET AF trial looking at all-cause mortality by type of AF. You can see that there is a huge difference between persistent long-standing and paroxysmal atrial fibrillation. So this is the patient that we need to attack as soon as possible. Then we have 2 trials, one with RF, one with cryo, looking at progression. If you do ablation instead of medication, how many patients progress from paroxysmal to persistent? Very nice trial. This is the ATTEST trial, and the outcome is clear. If you do the ablation and you compare to medication, it's actually much better for the progression. Less patient will progress to persistent atrial fibrillation. And let me go to the New England trial that was presented last AHA here, where they did the same thing. They randomized patients to optimal medical therapy versus ablation to look at the progression of atrial fibrillation. All patients have an ILR. They treat with flecainide, propafenone, sotalol, dronedarone, patient with normal and abnormal EF. It doesn't matter. and 75% reduction in progression to persistent atrial fibrillation, and 51% reduction in sinus rhythm maintenance with ablation versus medication. Incredible outcome. And if you look at secondary outcomes, the burden of atrial fibrillation, less with ablation, the quality of life of the patient, much better with ablation. More importantly, rehospitalization, emergency department visit, rehospitalization, number of cardioversion, and everything. When you look at the safety, there is safety issue everywhere. Ablation had 1 death, 3 cases of self-limit phrenic nerve palsy, and 2 pacemaker implantation. But antiarrhythmic drug, 1 death, 2 causes of wide complex tachycardia, 2 heart failure exacerbation, 3 acute coronary syndromes, 3 neurological events. So I don't think that is bad, best for you.
Sorry, we rehearsed this. Everything is going according to plan, but timing matters. We discussed. So we have 7 minutes. I have 7 more quick cases. The first one is my patient had an EF of 50%, developed atrial fibrillation, and now it's 35. We're going to ablate this patient. No, don't say it. I have 6 more patients where my script says Luigi will recommend ablation. So I have convinced my patient to have an ablation, but my patient said to me, you know, my friend has the same problem that I have, and she had an ablation 5 years ago, and she had a complication.
Okay.
What can you tell me about that?
So we're not going to talk about progression any longer. We go for complication. Okay, so I would like to show you that
of the art ablation.
Complications are in everything. I show you the complication of medication already in the prior trial, but these are the complications of ablation. You can see that they trend down dramatically to about 3% in Europe. These are 2 European trials here, from 6% to 3%. This is a JACC paper here, looking at the trend of complication from this years, more old, versus more recent year. You can see in red, there is a trend towards reduction on overall complication. This is the central illustration. You can see that the worst complication is now the vascular access complication. We have a lot of other complications like tamponade very down at 2.7%, but really they are 3%, no more. We have a beautiful editorial written by my coworker, Dr. Ferrick, about safety in numbers. The more ablation we are doing, the more we're getting better. And don't forget that we also have new energy source. We use RF and cryo, but soon we're going to have a non-thermal ablation, PFA. We've been doing all the IDE trial here with the FDA. In Europe, they already have it, where there is no risk of damaging surrounding structures. There will still be risk of access complication, but no thermal, and so no fistula, no phrenic nerve palsy, no PV stenosis, no stiff left atrial syndrome, no thermal perforation. So we are getting much better. We have the same access than when you do biopsy or when you put one on your device right now. It's vascular access complication. And so I think we are going to do better and better. So I also want to remind you the slide on amiodarone, which is the most utilized one. This is what we do all the time. We give a lot of amiodarone to our patient, but these complications are not bigger than the ablation. So I think we should keep in mind. And I want to conclude saying that we have 2 trials that I mentioned the most, the ATAC on amiodarone and the Castle AF. So the strategy is attack the Castle for everybody, send the patient to us as soon as possible. And that for me, I like music. The only music I hear in the EP lab is sinus rhythm. Thank you very much.
That was really great. Any questions? We have 3 minutes, and we have to rapidly clear the room for medical grand rounds. But do we have any questions? Regis, so high volume center. How many ablations are done at Montefiore in the system?
Well,
this morning. No.
in every, if I put together the hospital, Moses Weiler, in the system we do more than 1,500 ablation
every year.
And every year, yes. And Moses Weiler, we have performed about 750 AFib ablation and more than 1,000 last year. So we have high volume. The definition of high volume is more than 50 procedure per operator on complex ablation. But more importantly, is also the volume of the hospital. So AFib ablation is not the operator, it's the staff preparing the patient to a procedure, the procedure, and the follow-up of the patient, including the heart failure management. So high volume center means not only one operator doing a lot of procedure, but the whole staff being able to manage all the procedures. It's not only the operator, the problem is an education that goes from the EP lab staff to the floor.
Yeah, and I think that's an amazing closing comment. It's also true for all the other diseases we treat here with a very large team, with an interdisciplinary team. And we're going to take a 1 hour break now for lunch. There's exhibits, there's some lunch boxes coming with a slight delay, and then we reconvene here for a really super interesting afternoon on structural heart disease and some other hot topics. Thank you.